Start. Can you start the recording? Yeah.
A very good evening to all. I'm Dr. Soumya Prasad, and it's my honor to moderate this highly relevant session on abnormal uterine bleeding in special population. We have a distinguished panel of speakers with us today who will share their insight across different age spectrums. To formally begin this proceedings, I would like to invite, can we have the slide, Dr. Sarita Bhalerao ma'am, Secretary of ICOG.
I think it's enough that Soumya, you have said that. And it gives me great pleasure to welcome you all for this last day of this certificate course on abnormal uterine bleeding. It's been the last 2 days have been just fantastic, and we've had an overwhelming response of over 1,000 delegates registering for this course. My thanks, sincere thanks to firstly the Foxy office bearers, Dr. Sunita Tandulwarkar, Dr. Suvarna Khadilkar for their support, to Dr. Parag Biniwale for all his guidance, and to our fantastic conveners led by Dr. Lakshmi Srikhande, very, very dynamic past chairperson of the ICOG, and Dr. Meena Samant and Dr. Pratibha Singh. I think this time we've had a record number of coordinators as well, and that has really contributed to the how smoothly the program has run. And I'd like to thank from day one onwards Dr. Supriya, Dr. Manan, Dr. Shrutika Thakkar, Dr. Suyoga, Dr. Apurva, Dr. Aishwarya. We have two Aishwaryas, Dr. Soumya, Dr. Aishwarya again, and Dr. Aditi Trivedi. So I'd also like to thank all the faculty who've put in a great amount of effort towards this program. And to all the delegates, thank you so much for being so active. I've been seeing the chat boxes and how they are asking questions. Before I end, I would like to welcome everybody. Please do take your FICOG this time. This time, the FICOG application last date is the end of September, and we will be giving the FICOG in Delhi during the AICOG conference. So please do go online, icogonline.org, and apply for your FICOG. Thank you so much, and back to you.
Can I also request Dr. Sadhna Gupta ma'am, Vice Chairperson elect, also to deliver the welcome address and share her thoughts? Sadhna ma'am, please share ma'am's CV slide.
It's okay. It's okay. It's okay. Fine. So, warm welcome to third day of this ICOG certification course on abnormal uterine bleeding. My sincere regards to Dr. Lakshmi Shikhande, Dr. Parag, and Foxy President Dr. Sunita, and Dr. Sarita have just delivered. So, Dr. Sarita is a backbone of the ICOG. Abnormal uterine bleeding, like Dr. Sarita says, that it has been the record registration, because very rightly the abnormal uterine bleeding is something which is our domain. We can say in like a professional term, it's our bread and butter, right from adolescent to the postmenopausal age group. And today the beautifully designed scientific program. So congratulations to Dr. Lakshmi, Pratibha, and Meena, that it is the age right from adolescent to postmenopausal bleeding. And we have the great expert and professors, Dr. Lakshmi, Dr. Meeta, and Dr. Sarita Bhalerao. And the second is the upcoming, which is the upcoming challenges. So fertility preservation, obesity, method, like it, the topic and the health issue of great concern in our country. And we have to actually reorient our clinical practice right from every field, every subject, and which include abnormal uterine bleeding as well. Dr. Sarita Agrawal, Professor HOD from AIIMS Raipur, she will be dealing with acute AUB, and this is something that very important, life-threatening, and where we can like caught up in the legal issues as well, because it needs urgent attention, maybe admission, and a very protocol-based care. Case-based discussion with Dr. Anju Soni and Manjal Pandya, and Dr. Hira Lal Kunar and Suchitra Pandit as expert, and with the galaxy of panel. We are looking forward to great discussion. Hearty congratulations that you have joined this ICOG certification course, which will everybody who has joined will give you a cutting edge in your professional practice. And we wish everyone a very enjoyable learning. Thank you very much.
Thank you. Thank you, ma'am. Can I now request our convener, Dr. Pratibha Singh, ma'am, also to give us a brief overview of today's academic sessions?
Join.
Thank you. Thank you, Dr. Soumya. So, hi, everyone.
First of all, I would like to warmly welcome you all for this final day of this certificate course on abnormal uterine bleeding. And the past 2 days have been highly successful and enriching. And I am really confident that today also it will be equally informative. We are privileged to have many eminent speakers today also who will be sharing their valuable insights on the treatment of AUB in special populations, that is ranging from adolescents to peri and postmenopausal women, as well as those those who are with comorbidities. So, without further delay, let us begin the session. And once again, I would like to welcome our esteemed speakers, chairpersons, and all the delegates who have joined for this course. And before we begin, a quick reminder that there is no pre-test and the post-test will begin shortly after the conclusion of all the sessions. So and also we have enthusiastic coordinators, Dr. Soumya, Dr. Aishwarya, and Dr. Aditi Trivedi. So welcome all of you. And with this, I hand over the program to start our first session. So over to Dr. Soumya.
Thank you so much, ma'am. With that, we now move on to the session 1. For that, I would like to invite our esteemed chairperson. Can we have the CV slides? Dr. Alka.
Dr. Alka is
she's
unable
not,
to join.
ma'am is not here.
Yeah.
Dr.
Yeah.
Rajshri.
Yeah.
Saw her. She is logged in.
She's logged in.
Yeah. I saw.
Madam, Dr. Alka Kumar, ma'am is Senior Consultant, Preventive Oncologist and Wellness Specialist at Shalka Hospital, Nagpur, practicing for 30 years, former Assistant Professor at RDG Medical College. Can we have the next slide for Dr. Rajshri Katke? Ma'am is Professor and HOD, former HOD Grant Government Medical College and ex-Superintendent of Kama and Albinus Hospital, Mumbai, renowned obstetrician and gynecologist and surgeon per excellence. Can we have the next Dr. Shubha Sethia, ma'am? Ma'am is Senior Consultant at Amar Jain Hospital, Surya Hospital, Sony Hospital, President Jaipur Menopause Society, Vice President Jaipur OBG 2021. I would request the chairperson to please introduce the first speaker, Dr. Lakshmi Shikande, ma'am.
Good afternoon to everyone. And at the first, I would like to thanks to Dr. Lakshmi ma'am, Dr. Parag sir, and the entire team of this, you can say ICOG certificate course. And it's a proud privilege to, to introduce Dr. Lakshmi ma'am, which is a very dear friend of mine, a very great person. She's a medical director and senior consultant of the Sri Kande Hospital and Research Center Private Limited from the Nagpur, Maharashtra. Ma'am has having various positions like chairperson of the Indian College of OBGY 2022-2023, National Corresponding Editor General of OBGY, India Jogi since last 8 years. It's very great commendable thing. National Corresponding Secretary of the MWI, then member of the SAPFOG, Vice President, ISOPAB, Joint Secretary, Indian Menopause Society 2024, President of the ISOPAB Vardha Chapter 2019 to 2021, then chairperson. The list is very, very big and all. And apart from that, the awards and the accolades what she has is the FRCOG, that is the Fellow of Honorary by the Royal College of OBGY UK, Nagpur Ratna Award, then received Bharat Excellence Award for the Women's Health, Best Committee Award for the HIV/AIDS 2007 to 2009 Foxy Committee, received appreciation letter from the Maharashtra government to work in the field of the Save the Girl Child, delivered 32 orations, signed 550 guest lectures, publication 62 national and 31 international, and sensitized more than 2 lakhs boys and girls on the adolescent health issues. So ma'am is a very eminent and big personality in the field of the OBGYN and expert, we can say IVF specialist, a very good teacher also. And apart from that, she is the one of the finest person also. So thank you so much for inviting me here.
Thank you. Thank you so much, Rajeshri, for your kind introduction.
Thank you, ma'am.
I am coming to the point, that is adolescent AUB. I'm sure you all will be very, very familiar with this case scenario which I have posted, that 17-year-old girl coming to you with irregular menses, heavy flow. Now the question is, what next? So you have to have differential diagnosis in your mind before you start your workup for this girl. First differential diagnosis in this girl is immature HPO axis. Second is bleeding disorder. Third is PCOS. And then comes other endocrinopathies. Don't forget to rule out pregnancy and pregnancy related conditions. Then there are other rare differential diagnoses in the form of duplication of Mullerian system, polyps, fibroids, pelvic infections, and iatrogenic cause in the form of if she is taking hormones, antidepressants, or anticoagulants. Once you have differential diagnosis in your mind, you have to start with the evaluation, because evaluation is must before you proceed with any treatment. So your aim of evaluation is to determine the severity of the bleeding and the possible etiology. That is, you have to narrow down on your differential diagnosis. Now, many of our adolescent girls are sexually active. So don't forget to keep pregnancy and its complications in the differential diagnosis. Bleeding disorders are responsible in 25 to 30% cases. Detailed history taking should be with parents and without parents, because without parents, she can confide in you about her personal life. And remember, whether it's an adolescent or any other woman, HMB is a subjective diagnosis. So on day one, we have told you how to go and assess the heavy menstrual bleeding in an objective manner. Don't forget to do general examination to look for signs of pallor, hepatosplenomegaly, signs related to the hormonal disorders like hirsutism, acanthosis. Gynec examination is not needed. Ultrasound is not mandatory in adolescent girls. If at all you feel that it should be done, then transabdominal is the route of choice. First investigation I have written is urine pregnancy test. You need not document it in your case paper, but go ahead and do it. CBC, ultrasound not necessary. Bleeding disorder, I will tell you in which cases you should do. You should not do all the endocrine tests in this girl, but yes, TSS should be done. PCO test, if only you suspect PCOS as a etiology for this irregular period. And ultrasound, I have told you again and again, it is not necessary. This is the study which I have quoted, that even if you do ultrasound, in 75% of the cases, it will come normal. And in another 2% cases, where you will find any pathology, it is not going to change your management plans. So in which cases you should go ahead and do the bleeding disorders. This is the list. You have to ask the personal history of bleeding disorders, family history, and whether she is having heavy bleeding since menarche. The frequently diagnosed bleeding disorders are von Willebrand, mild platelet function, and mild platelet factor deficiencies. This is the first line, second line, and third line test. Yesterday we had a detailed talk by Dr. Aswath on AUBC, that is coagulopathy. It is very important that when you are ordering for von Willebrand panel, it should be obtained when your patient is not taking hormones, because exogenous estrogen may elevate this factor into the normal range. Thus, it should be obtained either at the time of presentation or after exogenous estrogen has been discontinued for 7 days. Also, you should know the blood group type of the patient, since blood group O is associated with low levels of VWF. So what are your management goals? It is to control heavy bleeding, prevent or treat anemia, prevent recurrence, and you have to treat the cause. So the management depends on underlying etiology, her need for contraception, her adherence and compliance capabilities, because many of them are running from one place to another. They are having their coaching classes, they have to attend their schools, colleges, and also you have to take into consideration the cost factor as well. There is significant overlap in the management of patients with and without bleeding disorders. There are various modalities available. First is NSAIDs, antifibrinolytics, hormonal, DDAVP, and replacement of missing coagulation factor. In any case of bleeding scenario, the first line is non-hormonal, that is start with NSAID, antifibrinolytics, and then think of giving the hormonal therapy. Adolescents with HMB where you are suspecting bleeding disorder should be instructed to avoid NSAIDs due to decreased platelet aggregation by inhibiting thromboxane A2 synthesis. Desmopressin, Dr. Aswath has told you in great detail. It increases the VWF and factor 8 levels as well as platelet additions, and its effect lasts for about 6 hours. When it comes to mild AUB, we don't resort to hormonal treatment. We try to manage it by non-hormonal therapy, and we call her for follow-up at 3-month interval. And of course, we tell her to keep a menstrual cycle diary. Moderate AUB, again, they are managed on outpatient basis. Here, hormone therapy is necessary to stabilize the endometrial proliferation and shedding. There is no consensus on whether to treat these cases with COCs or progestin-only regimens. COCs are a better choice as estrogen improves hemostasis. You can give them monophasic COCs which contains at least 30 microgram of ethinyl estradiol, as this will prevent the breakthrough bleeding. And if she is not able to tolerate the estrogens, you can give her antiemetic therapy as well. Once you start COC, it should be continued for 3 to 6 months. Progestin-only therapy can be an alternative to COCs for adolescents who are not currently bleeding or they have a contraindication to estrogen therapy. There are different progestin preparations available. They can be micronized oral progesterone, 200 mg per day, medroxyprogesterone, 10 mg per day, norethindrone acetate, 2.5 to 5 mg per day, dipomedroxyprogesterone acetate or LNG IUS as well. However, the last two options are for those adolescents who want to have a contraception benefit as well. Oral progestins are given for 12 days every month, and bleeding usually occurs 2 to 7 days after cessation of your progesterone preparation. In all cases who are having severe HMB, they have to be admitted to stabilize them. And the approach of giving COCs is similar to that in moderate AUB, that you have to start with the COC preparation which contains 35 to 50 microgram of ethinyl estradiol. Don't give them low dose of COC pills. You have to eliminate the bleeding disorders before you start them on hormonal treatment. The treatment with high dose estrogen is continued at 6-hour intervals until the severity of the bleeding decreases. Then you can decrease within 1 week as follows. You have to give 1 pill every 6 hours for 2 days, then every 8 hours for 2 days, every 12 hours for 2 days, and finally 1 pill daily for minimum of 6 months. Here again, you will need antiemetic therapy. Where the bleeding is controlled with 50 microgram of ethinyl estradiol dose, you have to continue with this dose at least for 1 or 2 cycles, and then you can taper this dose to 35 microgram for remaining 4 months of your treatment. Bleeding usually is controlled within 24 hours of your OCP treatment. High dose progesterone is an alternative treatment choice in those patients with severe bleeding, especially where estrogen is contraindicated. And in these cases, you have to give medroxyprogesterone in the dose of 20 to 40 milligram or norethindrone in the dose of 5 to 10 milligram 3 times per day for 7 days. More than 90% of severe bleeding that occurs in adolescents is controlled with medical bleeding. However, the indication of surgery in adolescent is in the case of life-threatening bleeding, when medical treatment is unsuccessful, or in those situations where you want to have a histopathological evaluation. So after treatment is initiated, you have to see and call your patients for regular follow-up. Long-term management depends on the degree of anemia and the desire for contraception. You have to continue hormone therapy for at least 6 months. After therapy is discontinued, the patient should be followed to ensure that she is having regular menses. Frequency of follow-up visits will depend on the severity of AUB. Each visit, you have to ask for compliance of your treatment, check her menstrual diary, educate the girl and her family members about the bleeding, about this HMB which she is facing. Don't forget to look for anemia, treat anemia, and prevent anemia. So the key takeaways are evaluation in an adolescent girl should include assessment of anemia. So you have to do serum ferritin if she is having less hemoglobin, if she is having endocrine disorder which leads to anovulation, and you have to evaluate for the presence of bleeding disorder. Routine ultrasonography should not be obtained. Hormonal treatment, because every time we get a query that whether you can give COC in an adolescent who is 14 year, 15 year or 16 year. The answer is yes, yes, yes. You can safely give COCs in an adolescent girl because it has a positive effect on her quality of life. It improves her school performance. It improves her social activities. It decreases the number and severity of bleeding episodes without damaging the hormonal axis during the maturation process. So after this talk, I want that you all should be confident enough to prescribe COCs to your adolescent girls. Don't forget to manage and treat anemia. Here, don't forget to take the opportunity to educate the girls and her family about the issues related to menses, the safe menstrual products, and about the menstrual hygiene as well. So in adolescent AUB, it is detailed history taking, objective assessment of HMB, general examination, ultrasound not needed, avoid low over labeling of PCOS that we have told you on day 1, the criteria for diagnosis of adolescent PCOS. You have to manage them medically, manage anemia, and take this opportunity to educate the patient and family. Thank you. Thank you so much for your patient hearing. And I request everyone to vote and support me for my upcoming election. That is, I am contesting for Foxy representative to AOFOG. Online voting will start from 1st of August and it will continue up to 10th of August till 5 p.m. Your questions, comments, and concerns are most welcome. You all can post them in the chat box. Thank you. Thank you so much.
Thank you, Lakshmi ma'am. You have enlightened on the topic very nicely. 3 important things which you have told us that one is the first is the arrest of the bleeding. The second thing is that maintenance of the bleeding phase, and third is the correction of anemia. And very rightly said, very rarely in 1.1% of the cases you needed to have, to do the surgical, you can say for the surgical intervention just for the diagnosis. In a rare cases where they have ovarian tumor with the endometrial hyperplasia, or you have some, endometrial pathology, which could be a malignant one. Rarely, but it can happen. And there is the role of this one. Very nicely told about the hormonal evaluation and hormonal how to go ahead with all these things. Very good, I think. And it will help all the youngsters how to go ahead with this.
Yeah. Thank you, madam. And there are questions in the chat box, madam, so you can answer that.
Yeah, I am answering.
Yeah. Thank you, Lakshmi ma'am, for that very clear and informative talk on AUB and adolescents. So now we go to the next talk, Dr. Meeta Gupta ma'am. Can the chairperson please, I request the chairperson to please request to
I was seeing
introduce
Dr.
ma'am.
Parag Binewale. Dr. Soumya, I think Dr. Parag has joined. If he's there, yes, Dr. Parag is there.
Pratibha, I'm here. I'm listening to the lectures. Please carry on. The program has started, so I'm not going to interrupt. I'm eager to listen to Dr. Meeta Gupta's lecture now. Excellent lecture, Lakshmi.
Thank you.
Dr. Meeta Gupta ma'am. Ma'am is Dean Academics Professor and Head of Department AIMS, Vijaypur, Jammu and Jammu. Winner of Women's Health Researcher Award, Senior Category, Advanced Course in Medical Education, teacher for the last 18 years with special interest in adolescent health and high-risk pregnancy. Over to you, ma'am.
Are my slides visible?
Not it. Now,
Yes,
now.
yes.
Now it's.
Make
Thank
it
you.
full screen.
Yes, ma'am. Thank you so much. At the onset, I would thank the entire ICOG team, especially Parag sir, Sadhna ma'am, and Sarita Balarao ma'am, as well as the conveners today, that is Lakshmi ma'am, Pratibha ma'am, and Meena ma'am, for giving me the opportunity. And with the permission of my chairpersons, can I start?
Yes, yes, please.
Thank you, ma'am. So today I'll be, after the crisp talk of Lakshmi ma'am, I will be talking about perimenopausal bleeding. So to define, perimenopausal is the transition that occurs from towards the menopause, and usually it is around 45 years. But as a teaching academician, we always say after 40 years, please be very careful and evaluate all these patients from point of view having abnormal uterine bleeding. So perimenopause would be the transition usually lasting 5 years before the menopause, and the symptoms may vary from menstrual irregularity, vaginal dryness, hot flushes, and sleep problems. I will be restricting myself to only the menstrual irregularity. So this abnormality could be in the duration, the volume, and the frequency, as well as the regularity or the irregularity in the menstrual pattern. The incidence is as high as 10 to 30%. It can be acute or chronic depending upon the presentation the patient presents with. So previously it was known as the heavy menstrual bleeding, as well as it encompasses the intermenstrual bleeding. Intermenstrual, that is between the cycles, and heavy when the cycles are regular but the bleeding amount is more. Previously, these various terminologies was used, but everything now encompasses in the perimenopausal abnormal uterine bleeding. So the causes could be uterine and extrauterine, which could range from anevolution, polyp, hyperplasia, endometritis, or adenomyosis in uterine. And extrauterine could be cervical lesions, genital malignancies, any prolapse having a decubitus ulcer, retained foreign body, pessary, IUCD, urethral caruncle, or in ovarian tumors. If you look at the FIGO classification, all of us by the end of this 3-day certifiable course would know about the palm coin classification. Just for the young generation, the new PGs, there were some changes as per the FIGO, which I will be telling you, that the parameter in relation to frequency, amenorrhea has been included. Once the regularity is there, the normal variation is from 7 to 9 days. The duration is only 2 categories have been included. Normal would be less than 8 days. A prolonged would be anything more than 8 days. The volume, we have to look at the NICE guidelines, because according to this, any bleeding amount which interferes with the quality of life of the women should be considered as a heavy menstrual bleeding. Intermenstrual is that anything that occurs during the menstrual periods. Then according to the system classification, AUBA would be having a sonographic diagnostic criteria. Leiomyoma, this would also have the type 3 submucous leiomyomas. These are just the changes that have been incorporated. The C coagulation would be the pharmacological agents that impaired the blood clot coagulation are now included in AUBI, that is iatrogenic. ABUI will include all the iatrogenic processes, including the pharmacological agents that interfere with the coagulation, anticoagulation, as well as the ovulation. O would be the ovulatory disorders where the diagnostic thresholds have been changed, and this does not include any drugs causing ovulation. And N, that is not yet classified to not otherwise classified. This is the nomenclature change that has occurred in the FIGO AUB systems. So once we are evaluating any patient who presents to us with irregular menstrual bleeding, then first and foremost is history, and patient perception has to be very detailed taken. The pictorial blood assessment chart has to be considered, and every PG student should make it a habit of including a pictorial blood classification chart in the OPD slips. We can have alkaline hematine method, but it is not practically possible. We have to count the days of the patient menstruating. The pad weight and hemoglobin length can be also used as an evaluation criteria.
This is what a pictorial blood assessment chart scoring is there. And I would request everybody to paste it in our OPDs because this will help us in our diagnosis, clinical diagnosis of the patient. This is the pattern that we have to use for AUB patient. The palm coin has to be mentioned, whether it is yes and no or query. Everything has to be documented in our OPD slips for evaluation of any patient in perimenopausal having AUB. So general assessment would require a history and a bleeding pattern. The physical, pelvic, general physical examination, pelvic and a per speculum examination, followed by lab investigation in which a CBC, iron studies, thyroid hemoglobin and a beta HCG levels to rule out pregnancy is a must. Any disorders of hemostasis would be done. We have to determine the ovulatory status. Then on a pelvic ultrasound, on evaluation of pelvic organs, the transvaginal sonography is one of the best. If further evaluation for endometrium is required, we would go for endometrial biopsy. And if hysteroscopy is available, that is the gold standard. So to reiterate, beta HCG or pregnancy test is the must. CBC to look for the anemia and the degree, the bleeding, coagulation, and the platelet count, prothrombin count, everything has to be evaluated to screen for coagulopathies. Thyroid stimulating hormone or TSH levels for thyroid abnormalities. Prolactin if she has any clinically indication, and cervical cytology is a must. For imaging, we know the transvaginal sonography is the best. Saline infusion sonography can also be used to differentiate endometrial polyps from submucous leiomyomas, but with the advent of 3D Dopplers, we do not require saline infusion sonography. Hysteroscopy is best for diagnosis and characteristics of intrauterine abnormalities, and MRI can be used to differentiate between fibroids and adenomyosis, and it is specially required for mapping the exact location of fibroids while planning any conservative surgery or prior to therapeutic embolization for fibroids. Coming to endometrial sampling, the primary role is to rule out carcinoma or any other malignant lesions in these patients as they are over 40. Use of transvaginal sonography can also be used in these patients. Coming to sampling methods, one of the best methods is a Pipple or a Carmen's phone number cannula. Vabra is also the new thing that has come. According to the gynecologist who is using, some may prefer Pipple and Carmen cannula 4, but both have been said to be the best in compared to office endometrial sampling. Please do not keep the patient for DNC or general anesthesia. Instead, always take out an endometrial biopsy by use of a Pipple or a Carmen cannula 4 because we may have a chance of losing this patient for follow-up. A pap smear is an unreliable test, but if we should have an additional benefit of doing a pap smear in these patients, and a DNC should be reserved only for patients who have cervical stenosis or the patient's tolerance does not permit evaluation by aspiration biopsy. If bleeding reoccurs after having a negative endometrial aspiration, please counsel the patient to have a diagnostic DNC, or if the patient has inadequate specimen on doing an endometrial biopsy. Hysteroscopic guided biopsies are the gold standard as they are more sensitive with the visualization as compared to a blind DNC, and the indications are clear that is unable to pass the Pipple sampler or the Carmen cannula. If there is inadequate sampling or the patient presents with atrophic endometrium with presence of thickened endometrium on Pipple evaluation, there is discordance between the symptoms, the transvaginal sonography report and the histopathology report. There is inadequate visualization of endometrium on transvaginal sonography. The patient's presents with recurrent menstrual bleeding, and there is an intermenstrual spotting which may suggest of an intracavitary lesion or polyp. These are some of the findings that we may get on a hysteroscopic guided biopsy. This is also help us to rule out any malignancy as per the look on hysteroscopic guided biopsies. So we have to understand that every perimenopausal patient has to be subject to endometrial biopsy to rule out malignancies. So endometrial AUB would have an initial investigation in which we would be having the ancillary, that is the blood investigation, thyroid and all, a physical examination to do a per speculum examination, and ovulatory function has to be taken care of. If she requires fertility or related medical disorders have to be screened for any coagulopathy. Likewise, the endometrium has to be evaluated. If we have to rule out hyperplasia or neoplasia, an endometrial biopsy is a must. If specimen is adequate, we want to rule out whether she has atypical hyperplasia or malignancy. If yes, she has to be managed as per the AUBM, that is AUB malignancy. Whereas if the biopsy is not having an adequate sample, then we will have to go directly to hysteroscopy followed by a biopsy. But if she does not have any risk for hyperplasia, then she can go directly treated on AUB, E or O patterns. So coming to polyp, TVS transvaginal sonography is one of the best diagnostic modalities, and these patients may be subjected to hysteroscopic guided biopsy and further removal of the polyp. So if she desires fertility, hysteroscopic polypectomy is the management. But if family is completed and patient is not willing to have not willing to have any operative, then hysteroscopic polypectomy followed by LNG IUCD insertion can be done. Coming to adenomyosis, it is a benign condition in which MRI may be used for mapping, and these patients can be managed. The latest that has come is this Musa group classification, which we have to use for, as a postgraduate student, you should know what is the classification of adenomyosis as per Musa group. So the treatment could be medical or surgical for adenomyosis. LNGs are preferred method. Combined oral contraceptive, Dynogest or GnRH agonist may be used as per your counseling and the patient acceptance. Definitive treatment would definitely be hysterectomy. And if you have availability of uterine artery embolization, that can be also offered to the patient. Coming to the fibroid, we know this is the FIGO classification. The medical management or surgical management would be done. AUBM malignancy, we know how we have to treat. Endometrial hyperplasia without atypia is only 3% chances into malignancy, whereas atypical would have 10 to 30%. If it is without atypia, LNG is the first line of drug, or medroxyprogesterone can also be used. Malignancy has to be treated as per. I'll just quickly finish. With atypia, hysterectomy if family completed, LNG if family is not completed. Without atypia, LNG has to be, coagulation profile have to be do.
Ma'am, I'm sorry to interrupt, but we
Done.
are running out of time. So if you
Okay,
could just
I'll be
conclude.
just completing.
Yes,
Yes, thank you.
thank you, ma'am.
Okay. So we know, just to complete, we know that if you have N not otherwise classified, that is uterine artery embolization. For endometrial pseudoaneurysm, uterine artery embolization has to be offered, and uterine isthmocele that is coming up, they would require a laparoscopic uterine isthmocele repairs. So the goal should be regulation of menstrual cycle, minimal blood loss, and improvement of quality of life. Non-hormonal treatment has to be the first line, followed by hormones. LNG has to be offered. Endometrial ablation and uterine artery embolization are the latest non-invasive, minimally invasive methods, and hysterectomy is the major or the definitive treatment. Thank you so much.
I think it was very comprehensive, and what I would like to say that always do a hysteroscopy. Office hysteroscopy is also one of the things which you can do. For that, never one should do for the blind DNCs or the blind biopsies in that. Always in a perimenopausal bleeding, because we may miss sometimes early GIN or early C endometrium also in that. So a patient frequently coming to you with the irregular, she is not responding to the medical line of treatment. Please give a thought of that, because most of the times we have treated the C endometrium where the persistently medically treated the AUBs in that. So there is a minimal or chance of having the missing the C endometriums, and it has been very nicely covered with the all the classifications and all, Dr. Meeta. Very nice talk.
Thank you, and I'm so sorry for exceeding my time limit. Sorry, ma'am.
No, not at
Shubha,
all.
please,
You are given because ma'am has finished in a time, so that time has been
the
this
time.
thing.
Shubha, please unmute yourself and conduct the third talk. Yeah.
Excellent talk. And
Dr.
just
Meeta,
one
Dr.
thing
Meeta,
I
there are
would say.
questions in the chat box. You can
Yes,
answer that.
yes, ma'am. I'll do it, ma'am. I'll do it.
Yeah, just one thing I would like to say, that this is the best opportunity where we have the time to say we can save the uterus. So use medical management, because menopause is about to come. The problems might resolve, and therefore this is the best time for medical management. This we should always keep in mind. Yes, now
Dr.
I would
Shubha,
like to introduce our next speaker for today, none other than Dr. Sarita Bhalerao. And as already said, that Dr. Sarita Bhalerao is secretary of the ICOG and one of the main person behind this program of 3 days on AUB. So first of all, my congratulations to the whole team of ICOG as well as Dr. Sarita for this excellent academic bonanza. And now Dr. Sarita is a consultant obstetrician gynecologist at Bhatia and Breach Candy
I think
Hospital
Dr.
in
Shubha, it's
Mumbai.
okay. Yeah.
Yeah, welcome, Dr.
Yeah.
Sarita, for your lecture on postmenopausal bleeding. I think this will cover the third part of our various ages where how to manage. So welcome to you. Welcome.
Thank you, Dr. Shubha, for that kind introduction. And am I audible? Can you see my slides?
Yeah.
Yeah, it's in slideshow. So at the outset, let me thank the organizers, especially Dr. Lakshmi Shrikande, for kindly inviting me to give this talk on postmenopausal bleeding. So, I'm going to start with a few basic facts. In India, the average age of menopause, according to the Indian Menopause Society, is 46.2 years, compared to 51 years in Western countries. How do we define postmenopausal bleeding? It's uterine bleeding occurring after at least 1 year of amenorrhea. Remember that majority of these patients will still have a benign cause, but there is a 1 to 14% who will have endometrial cancer, which is a very serious consequence of this symptom. The most common cause is genital atrophy, which occurs in 60% or more cases. And our responsibility as gynecologists is prompt and effective evaluation to exclude precancer or cancerous lesions of the genital tract. That is our main objective. And the commonest symptom of endometrial cancer is abnormal uterine bleeding or postmenopausal bleeding. So the first thing is, what is our clinical assessment? And I think some basic important things are, we need the age of the patient, the age of menarche, and the age of menopause, because now we know that earlier menarche, later menopause has a higher risk of endometrial cancer. We also need to know how far she is from menopause. If she's had menopause in 2 years or 3 years, the incidence of bleeding is more. But if she's had menopause 10 years back, 15 years back, then the incidence of endometrial cancer goes up. Her parity, medical problems like hypertension and diabetes, which contribute to the corpus cancer syndrome, any family history of similar of ovarian or breast cancer, and use of anticoagulations or menopause hormone therapy. And today, many patients are on medication. Sometimes they don't know even what they are on. So it's important to ask them a history of all medications given by even other doctors. And some rarer things like HNPCC, etc. Triggering events like sexual activity could lead to postmenopausal spotting or bleeding. And on examination, the BMI is very important. Cervical pathology, take a pap smear, rule out vulval and vaginal causes, look for genital atrophy, and rule out bleeding from urethra or from rectum, because sometimes patients misinterpret vaginal bleeding. Then we come to, why does this occur? And atrophic endometrium is the most frequent cause of postmenopausal bleeding. What happens is that there's a hypoestrogenic environment, there is genitourinary atrophy, there is no fluid to reduce the friction. This leads to epithelial micro erosions, chronic inflammation, and this typically leads to light bleeding or vaginal spotting. And in these patients, pelvic ultrasound will typically show a small uterus, thin endometrium, and small ovaries. So if you have an ultrasound in your clinic and you do it and you see a lining like this, which is thin, a small uterus, a thin endometrium, and small ovaries, then more or less you have an idea that this looks like it is nothing very serious. Then we come to the next thing. So transvaginal sonography is the first investigation. Often can be done in gynecological settings or sent to the radiologist. It's important to visualize in the sagittal plane. Remember to measure the endometrium at the thickest part and try to see the endometrial echo right from the fundus to the cervical canal. Endometrial fluid should not be included in the measurement. And remember that almost 40% of patients with increased endometrial thickness will have polyps or hyperplasia. So it's very important to take that photograph and to record what is the thickness. Some patients are particularly difficult to do sonography. If they are obese patients, if they have large myomas, if they have adenomyosis, they are difficult. But a good endometrial thickness is very important. And you can see the picture on the right-hand side, which shows you a thick endometrium. It should be measured very carefully and recorded. And the probability of cancer is only 1% in women under the age of 50, but in a woman who has postmenopausal bleeding at the age of 80, the probability of cancer is much higher, 25%. So keep that in mind. So there's a wonderful article by Carlson et al. And if you see this review article, which talks of endometrial thickness and cancer findings in postmenopausal women with bleeding, what you can see is that when you look at an endometrium of 3 or 4 or 5 millimeters, the negative predictive value is very high. That means that the probability of there being a cancer is very low. And therefore, if the patient has a thin endometrium of 3 or 4 or 5, though we can't say for sure 100%, because rarer cancers can occur in atrophic endometrium, we can more or less be rest assured that if the endometrium is 3, 4, or 5, the chance of endometrial cancer is less. And therefore, if you look at this data, which shows the composite data on a misdiagnosis of endometrial cancer, based on the different thresholds of endometrial thickness, you'll see that if we take 3 millimeters, we will just miss out 1 in 383. If we take 4 millimeters, we'll miss 1 in 339. And if we take 5 millimeters, we'll miss 1 in 239. So mostly international definitions now say that an endometrial thickness of 4 millimeters or less has a greater than 99% negative predictive value for endometrial cancer. This was the ACOG committee opinion in 2018, and it still holds true very much so. So therefore, the recommendations are that if there is the first episode of bleeding, if the endometrium is thin, then no further evaluation. Persistent or recurrent bleeding needs additional evaluation. If the patient has high-risk factors, she's had a history of PCO, she's type 2 diabetes, she's obese, she's had atypical glandular cells on pap smear, then endometrial sampling should be done as a primary thing. We are not going to wait. A thin endometrial echo may still be seen in rarer cancers like papillary serous, mucinous, and clear cell. And therefore, we have to still follow up the patient carefully. And I think Dr. Sonal Panchal showed beautifully the day before yesterday that today with 3D sonography, with saline infusion sonography, they are able to visualize really very, very beautifully. But then what about sampling? So I think Dr. Meeta did mention about outpatient endometrial sampling. It's a very quick and simple technique, and the detection rate is good. But there is a chance of insufficient tissue because there may be a focal lesion. And in 20% of postmenopausal patients, PPL is not possible because it is difficult to enter the cervical canal, and an adequate sample may not be obtained. But having said that, this is a very useful PPL. This is what we have available and I have in the clinic, and it is one of the things that you can consider doing if it looks like it's a global change and not a focal change. Then we come to, of course, what is the gold standard? That is hysteroscopy with endometrial sampling. and a directed biopsy, removal of polyps are the most important. And if you see this, you can see that doing a hysteroscopy is really very helpful. You can visualize the whole cavity. You can see what is the pathology. You can take a targeted biopsy. You can remove polyps at the same time. Yes, sometimes it's difficult to do hysteroscopy in postmenopausal women. You can consider giving misoprostol and using a smaller scope like a 2.9 millimeter scope. And of course, there are risks of perforation when the uterus is very small, but I think that one should not be worried. And I think that this is really a very helpful thing. And you can see here that there is a big mass lesion in this hysteroscopy. I'll just, yeah. And here you can see, I'm also going to show you a small polyp, and I'm going to show you how you can at the same time go in and remove the polyp very easily with a scissor or with a resectoscope, whatever you are comfortable with removing. Yeah. So you may get a normal premenopausal proliferative and endometrium with 1:1 gland ratios, or you may get a polyp, or you may get endometrial hyperplasia, or now it is called endometrial intraepithelial neoplasia, where there's a disordered proliferation of glands, elevated gland to stoma ratio on crowding of glands, or you may get an endometrial cancer. Remember that endometrial cancer, one, is on the rise. Two, in women below 50 years, the risk is much less, but the risk goes up with age. And today we are finding a rising incidence of endometrial cancer. There are two types. There's a well-differentiated type, which is 90% of cancers, which involves the glands, low grade and confined to uterus. And there's a rare, poorly differentiated type 2, which are the sarcomas and the carcinomas. And these are aggressive with a poorer prognosis. Sometimes MRI can also be helpful, and you can do a contrast enhanced MRI. At the same time, it can tell you myometrial invasion, and it can help you in surgical planning. Now, women on menopause hormone therapy, if they're on sequential, they will have regular bleeding. But if they are on continuous progesterone estrogen, they may have irregular bleeding for the first 6 months, and it should cease after 1 year. And remember that long-term use of phytoestrogens can also cause bleeding. Women on tamoxifen are a different group, and here there's an increased incidence of endometrial pathology, and patients, the cutoff is 8 millimeters or more. If they have that, then it is better to do a hysteroscopy and a sampling. And there is a higher incidence of endometrial cancer in these patients. The duration of tamoxifen use is also important. Many patients are on tamoxifen after breast cancer. We have to follow them up very carefully, and there are very beautiful articles on the endometrial thickness in tamoxifen treated patients. So we have many, many algorithms, and this is a really simple algorithm where you look at the pap smear, you look at your clinical examination, you look at the endometrial thickness. If there are no risk factors, you wait and watch. There's no need, but if there are risk factors, then please go for a hysteroscopy with endometrial sampling or even an outpatient endometrial sampling. Thank you very much for a patient hearing.
I think it was very nice and very enlightened on the postmenopausal, because this is the most important thing. And what I would like to liked about the studies where there is one point in that also ki if suppose we have a 1 millimeter of this also thickness, then there are also chances in some of the cases of that. So that cutoff line is very important for everyone to go for the around 4 millimeter or 3 to 4 millimeter. And very nicely covered everything, how it affects into the Indian scenario, and even with the Western world. I mean, the basic differences and how to investigate it, how to tackle, and what are the very sensitive areas where you are supposed to pick up at the same time to diagnose the postmenopausal bleeding in a benign conditions. Excellent talk, Dr. Sarita ma'am. Very nice.
Shubha, Shubha, unmute yourself.
अरे, I
An
haven't seen.
excellent talk, Dr. Sarita, and especially the way you highlighted the difference in the endometrial thickness, which occurs when we take the hormonal therapy or tamoxifen. So we have to be very careful when we are evaluating these patients on to what treatment they are taking. So that was a very excellent take-home message. So an excellent and very concise evaluation of postmenopausal bleeding. Thank you so much.
Dr. Alka Kumar, are you here? Dr. Alka Kumar?
Um,
No.
No.
Ma'am, I think
Yes,
it's not
she-
join, I think.
Yeah.
With-
She's not well here.
Madam, Sarita madam, it was excellent talk. And
With
there are
that,
few questions in the chat box if you can answer. Thank you.
So with that, we conclude the first session, and I'll pass on my the second session to my next co-partner, Dr. Aditi. I think she's taking over.
No, it is hello.
Yeah, Aditi, you are audible.
It is Aishwarya actually. Soumya?
Yes, ma'am.
Okay.
Sorry to interrupt.
Aishwarya.
Actually, the second
Yeah,
session I am
Aishwarya.
supposed to coordinate.
Yeah.
Aishwarya.
Aishwarya, please.
Hello. Yes, am I audible?
Yes, yes, you are.
Yes.
So we are almost midway the session. So without wasting time, further I introduce the eminent chairpersons for this session, Dr. Durga Shankar Das, sir. He is Governing Council Member, ICOG 2024-25, Scientific Committee Chairperson, National Foxy, past Chairperson, and National Coordinators for many Foxy CMEs like Sexuality, Health, Happiness, and Harmony. And he's a core committee member, Foxy Cell on Sexual Violence. So, yes.
Next slide, please.
Next paper. Next slide.
Next, we have the eminent Dr. Rajendra Nagarkatti, sir. He is honorary librarian of MOGS, immediate past chairperson. Okay. Sir, cannot see sir joined here yet.
Yeah, he is not joined. Next.
Yeah, next slide. Can we have next slide? And then the last chairperson for today, she is Dr. Vanita Madegood, ma'am, a medical director of Care Hospital. Even ma'am is yet to join. I've called her. She may join in some time.
No issues.
No issue. So I think
Durga,
I
please.
hand over to the chairperson to Dr. Durga, sir.
Yeah.
Hello, am I audible?
Yes.
Yes.
Yes. So the first speaker is Dr. Atul Ganatra.
Sir, your
Okay.
voice is echoing. Sir, the
Is
voice.
it echoing?
Sir, you have joined with two
Yeah.
Devices.
I think you have
Yes.
switched off one. Yeah.
Hello.
Yeah. Good.
Yes,
Is
yes.
it okay?
Yes.
Yes,
Yes.
sir. Yeah.
Hello.
Yes. Yes, Dr. Durga.
Is it okay?
Yes. Yes. Please go ahead.
Yes. So some time is already spent. So Dr. Atul Ganatra, so is a very well-known figure in Foxy. He was past vice president, past chairperson, and eminent endoscopist. He was past president of Indian Association of Gynecological Endoscopists. He was past secretary also. So there are a lot of laurels to him. So I should not waste his time, and so that our talk will be curtailed. So now the microphone is yours.
Thank you.
Atul, please.
Thank you very much. So thank you. I can see some very eminent faces, and Rani of Nagpur is already there. So
Yes.
thank you very much, Dr. Pratibha, Dr. Meena, Dr. Lakshmi. Of course, Nilima from ICOG, who never leaves you, and Aishwarya for coordinating this session. There's one saying that has probably been with me for the last 32 years. Once you stop learning, you start dying. And learning is a constant process. And I just went through the program. It's a very extensive, exhaustive program on AUP. And I think anybody who's has any doubts will probably have them cleared in this particular session. Thank you, ICOG, the big boss Parag, for the entire program. Of course, Dr. Sunita, Dr. Sheila Mane. And my job is today to talk on patients who have AUB and need to preserve their fertility or need to have their uterus conserved. This is a no-brainer. You can see here, this is a patient who came to us and says that I just want my fibroids to be removed. I don't want to do a hysterectomy. And we removed 36 fibroids from her. Today's world, you only suggest treatment. You don't insist or you don't advise. It is the patient who decides what she wants to do. This is again a no-brainer. patients with infertility, with multiple submucous fibroids. There is no question that this patient needs surgical management. There is no role for medical management. This patient is an international patient now with 5 submucous fibroids. So that diagnosis is extremely important. But sometimes you can get foxed. This is a patient who came to us after having inserted a LNG intrauterine device or a Mirena, and she continued to have bleeding. Unfortunately for her, this Mirena was inserted in the OPD without an ultrasound. And if you see this ultrasound picture, this patient has the Mirena, but also has a submucous fibroid, which was probably completely missed. I think the most important part of treatment is diagnosis. Look at this submucous fibroid, type 0 fibroid. How is this Mirena going to help? There is no question. Young girl, 34 years old, 1 6-year-old child. I can never forget this patient because when we told that you have a fibroid, that's to be removed, she said, I was picked up and difficult to justify. This is another very, very difficult case which we had to manage. This is a 12-year-old girl, or rather a 15-year-old girl, you can see, continuously bled for about a month. Though my topic is fertility preservation, I'm going to talk about this particular patient. She continuously bled for a month. She was given everything right from norethisterone to methoxyprogesterone to leuprolide to depo-provera, and her bleeding wouldn't stop. And ultimately, last year when I was not well, I requested Dr. Krishna Kumar to come in and do a hysteroscopy on this patient because we just didn't understand. The USG was always normal as to why this patient was bleeding so much. And you can see this video. This girl, we did an office hysteroscopy, 2.8 millimeter scope. She had a very large erosion. You can see that erosion here. Not sexually active, and she was bleeding from this erosion. You can see the neovascularization. And I requested Dr. Krishna Kumar to go in and cauterize this erosion. And finally, this patient was given leuprolide, aquaviron, everything that was there under the sun. The treatment was something else. So I won't go into the details of this case, but this patient finally did spot. She said, I would have discharged and I will have bleeding or spotting. She was a young child who couldn't understand what her problem was. So what is our job when you have a patient with fertility preserving and she has abnormal uterine bleeding? It can be a concern for women who wish to preserve their fertility, as some treatments can impact future fertility. However, various options exist to manage these patients: hormonal, non-hormonal, and hysteroscopy or myomectomy. You can even do a lap myomectomy. The main job: differentiate etiologies, identify appropriate diagnostic evaluation, implement optimal management and approach for a patient, apply interprofessional team strategies, especially in patients with coagulation disorders. As we work in a tertiary hospital, we see patients with platelets as low as 2,000 with ITP, and we have to manage these patients as well. INR of 5, INR of 3, patients who are taking warfarin for metallic valves. This is something that has been discussed, I'm sure, many, many times. You need to make a diagnosis, and that's why ultrasound is extremely important. Type of fibroid, we need to find out whether she falls into one of these categories. Extremely important is history taking, right from obstetric history to desire for fertility to current contraception. I'll tell you another story of a patient who came to me. She was just 24 and she had continuous bleeding for the last 20 days. We gave her everything that we could, but the bleeding wouldn't stop. So one day I made her sit and says, "Bacha, what is the problem? Why am I not able to stop the bleeding? Have you taken any tablets? Have you done something that, haven't told me something?" Said, "Nothing much, doctor, but I took 7 eye pills this month. Last month, rather. Where on earth am I going to be able to stop her bleeding?" So I just counseled her, gave her tranexamic acid, and I said, "Your bleeding will settle down after a couple of weeks." Investigations, duration of flow, measurement of hemoglobin, ultrasound, assessment of the cavity, and assessment of coagulopathy. This is very, very important. Testing could be just a CBC and thyroid, or if you suspect anything on the CBC, you could get all the other investigations done, including a thyroid test. Presentation, how many pads does she soak, has to change pads and tampons. This is the quantitative estimation. Very often a patient will say, my bleeding is okay, but her hemoglobin is 6 grams. Other patient would say, I have very, very heavy bleeding. Her hemoglobin could be 13 or 14 as well. This is an excellent book. I think all of you all must read this book, The Management Guidelines of Abnormal Uterine Bleeding. I was a part of this team who did exhaustive study and discussion. I remember we sat in AIMS for hours together and made these guidelines, and I think everybody should go through it, especially postgraduate students. And this talks about all the types of abnormal uterine bleeding, which is there in the Palm-Coin classification and how they need to be managed. And presentation, I think one thing, if you're not able to stop the bleeding, one CBC report is extremely important because it will tell you give you a lot of information as to whether you're dealing with a coagulation disorder. We recently have a patient with von Willebrand's disease who wishes to conceive, and the hematologist is saying that her disease is so severe, it is difficult for us. She'll need a lot of IVIG before we can allow conception. Unfortunately, she also has endometriosis. So we need to go stepwise, do routine investigations, take first history taking, routine investigations, ultrasounds, decipher the investigations properly, and then do an ultrasound and take it from there. In patients less than 40 and more than 40, as to how you will look into these issues, irregular bleeding, obesity-associated hypertension, PCOS, diabetes, endometrial thickness of more than 12 obviously needs a biopsy. Adolescents, I think this is one place where we definitely need to be very, very patient. We need to be very, very cool, because my youngest patient with AUB was 7 years old and I didn't know how to talk to her. And her mother was extremely upset when I told her that she may need hormones. Her hemoglobin was only 3 grams. So I think this is where a lot of counseling needs to be done with these patients. There are a lot of guidelines which talk about doing biopsies, and there is no question about it. I think the ultrasound, if you put an ultrasound probe 9 or 10 times, the diagnosis is already made. For young girls, I mean, almost every day we see patients either with dysmenorrhea or with menorrhagia, that is heavy menstrual bleeding. Hysteroscopy should be a diagnostic tool only when ultrasound results are inconclusive. If imaging shows the presence of fibroids, appropriate treatment should be given. We can do a senile infusion sonography, but today now this is not necessary. You can do a good 3D ultrasound, MRI, if you have to do mapping of the fibroids. Dilatation and curettage is definitely not to be done. You could just do an endometrial biopsy. If otherwise, hysteroscopy, I think office hysteroscope is the rule. As far as management is concerned, you could give antiviral antibiotics, you could give NSAIDs, OC pills, oral progestogens, GnRH analogs, LNG-IUS, SERMs, especially in a certain category of patients, and we'll come to that. I think the word curettage should be taken away in gynecology also. MBA should be done so you can get a proper biopsy. Ablation, embolization, resection, hysterectomy is out because the patient wants fertility. Medical therapy is usually considered as the first line of treatment. However, where a pharmacological treatment is ineffective and inappropriate, you may need to do minimal invasive surgery. A sound knowledge of the 4 generations of progesterone is extremely important. Extremely important, and we must know which progesterone works for which patient. For example, if I have a patient who's about 20 years old, she has a lot of acne or pimples, I'm going to give her cyproterone acetate. Oral contraceptive pills, the first generation, norgestrel, medroxyprogesterone, second generation, LNG, third generation, norgestimate, desogestrel, and of course, the 4th generation, drospirenone. I think this is one of my favorites, unless I have a patient with acne, slightly higher risk of DVT, but as compared to the others, extremely safe and extremely well-tolerated medication. This is the evolution of progesterone, which all of us must know by heart on your fingertips. We go right from 17-hydroxyprogesterone to spironolactone or drospirenone. Now, the most important thing, please do not do any harm. And that's why when you write a hormone prescription for a patient, please counsel the patient well. Spend an extra 5 minutes with her to tell her she cannot forget her pill. She has to take it regularly. If she's on an OC pill, if she forgets one, the second one should be taken the next day. These are some things that have to be told to the patient. There was a huge health issue concerning the pill, the danger of the pill. And my mentor, Dr. Noza Sherrier and Professor John Gilbo always said, all medicines are safe, some women are dangerous. And we need to identify these women who are prone to develop venous thrombosis, stroke. I've had about 7 patients who have come to us with cavernous sinus thrombosis. One of them was our residents. Oral contraception, combined oral pills and progesterone taken in multi-dose regimes are commonly used for AUB. OC pills administered 3 times a day for a week if a patient's bleeding is very, very heavy, and then gradually you can bring them down to once a day. There are other medications that we need to use medical eligibility criteria before we prescribe a pill to a patient. Every patient who has a hormonal prescription at our clinic has this stamp which says headache, giddiness, nausea, vomiting, and leg cramps. You need to report to us immediately. Others, these are not available in our country. Combined oral pills, I think a lot has been spoken about it.
So sorry to interrupt. If we could just end it in time.
Sure, I
Yeah.
will do that.
Yeah. Thank you.
I think I'll just finish by ending. I have a couple of slides more, but I think LNG is something that I want to talk about, which is one of my favorite. And this is one of the most commonly used medication that we use, or a minimal surgical management that we use. And this is our paper we have presented at the Paris conference and in the ICOG journal, where 100 patients of LNG IUS was used, and in a retrospective study, and we've had a 94% success rate. Thank you very much for the patient sharing.
Hello, Durga, are you here? I think he is not there. Durga,
Yes.
please.
I'm here.
Yeah.
I think everything as was previously discussed and well taken up today. Nothing more we should discuss and proceed to the next speaker. Is it so? Or Lakshmi, you would like to add anything? I
Thank
think
you, Atul.
these
Thank
things.
you so much for
Yeah.
logging in. I know you are so busy, but you are always there when I give you a call. And I can't see any questions as of now, Atul, but if there are, you please answer in the chat box before you log out. Yeah.
Sure.
Thank you.
One thing is sure,
Thank you,
Atul was
Dr.
very focused.
Yes.
Atul was
Yeah.
very focused. Good one. Okay, let us proceed to next.
Dr. Vinita is there, I think.
Yes, ma'am.
Yeah, Vinita. Vanita, please introduce our speaker. Yeah.
Introduce us.
Yeah, it's Dr. Meena Samant. Hello. Yeah.
Hello, ma'am.
Yeah. I'm sorry for joining late. Dr. Meena Samant is a senior consultant and HOD. Her Holy Family Hospital, Patna, Bihar. She is a past president, Patna Obstetric and Gynecological Society, and past secretary of General ISOPAS. And she's a chairman of FOXY, Clinical Research and Committees. And she's a awardee of Kamini Rao Oration. And she's organizing secretary and organizing chairperson for a FOXY PPH Con 2024. And she's a DNB teacher, and she has published many papers to her credit. And we have an eminent speaker today for us for the today's session. And I request her to proceed her talks.
Ma'am, for
Yeah.
the elaborate.
Yeah, the topic is women with obesity and comorbidity. Please share your slides, ma'am.
Share your screen.
Is it visible?
No, Meena.
No.
Atul, if you are here, please put the name of the book which you showed on your PPT. Everyone is asking for that. Is he logged out?
I don't know what's happened. What do I do?
Don't panic.
Just
Share again.
go on, share your screen. Yeah. Now it's coming.
It's coming. Yes, it is.
Yeah.
Yeah.
Great.
So,
Great.
Make it full.
good evening, everyone. Respected chairpersons and all the delegates, I'm going to speak on AUB in women with obesities and comorbidities. We all know obesity is associated with abnormal uterine bleeding, and obesity which it occurs across all ages and all social strata as well. There is a clear association between obesity and the development of endometrial polyps, polyps, the endometrial hyperplasia and ovulatory dysfunctions. As PCO is associated with obesity and obesity augments its development, many of the effects of obesity on menstrual disorders may be manifested through an ovulation and PCOS. Now, the link between HMB and obesity is corroborated by Sain et al., who found that severe HMB was more prevalent in the population with obesity than those with normal. Also, this cross-sectional study looking at relationship between menstrual disorders and obesity in 2,000 adolescents identified association between menstrual disorders and obesity, and we can see all prolonged menstruation, amenorrhea, dysmenorrhea, HMB, and intermenstrual bleeding were all more in these girls. Now, obesity in adolescents has been linked to earlier puberty and menarche, resulting in adverse psychological and behavioral outcomes, along with higher rates of abnormal uterine bleeding, amenorrhea, PCOS, and dysmenorrhea. Obesity is also independently associated with metabolic and hormonal abnormalities, hyperandrogenism, high fasting insulin levels, and lower levels of sex hormone binding globulin. Now, the elevated circulating estrogen levels result in negative hypothalamo-pituitary gonadal axis and subsequent menstrual abnormalities and the ovulatory dysfunction. It is linked to risk of atypical hyperplasia and endometrial cancer due to high estrogen levels. Also, an increase in BMI of 5 units results in a 50% increase in the risk of postmenopausal bleeding if we talk about postmenopausal women. And excessive adipose tissue also results in chronic inflammation secondary to production of pro-inflammatory adipokines and a decrease in anti-inflammatory cytokines, impairing the endometrial DNA repair. The hyperinsulinemia and hypoglycemia further promote endometrial proliferations. And we know that we do get a lot of class 3, that is more than 40 BMI patients, and metabolic syndrome, that is high insulin resistance, visceral obesity, hypertension, high triglycerides, low HDL. They all go hand in hand. They may be coexisting in most of the patients. So hypertension, diabetes, glucose levels, and the consumption of high glycemic food loads have been found to be positively associated with endometrial cancer risk, mostly among the overweight and obese women. Now, the prevalence of hypertension and diabetes were detected higher among the women with cancer and hyperplasia, what we famously has been going by the name of corpus cancer syndrome that we since PG times. Now, once a patient with obesity or some metabolic condition comes to us with abnormal uterine bleeding, our initial assessment would be a thorough history examination, appropriate investigations including a full blood count. Transvaginal ultrasound has traditionally been the first-line imaging modality for HMB, and if transvaginal ultrasound is declined, transabdominal ultrasound or MRI can be offered as an alternative imaging modality. Outpatient hysteroscopy may be appropriate and effective diagnostic tool in those suggestive of uterine pathology, wherein see and treat or taking a biopsy could also be done at the same setting. And of course, transabdominal ultrasound would have its limited value in these patients. Now, coming to the treatment part, we know lifestyle management changes are so very important when you think of obesity. And a weight loss of around 5% results in significant improvement in the symptoms of PCOS. So whenever we are managing a obese patient, this is the first thing that we have to talk about. Continued efforts to make lifestyle interventions such as weight loss, increased physical activities, measures to control insulin resistance and hypertension could reduce the prevalence of endometrial pathology in general population as well. Now, more specifically, levonorgestrel releasing intrauterine system LNG-IUS, it remains the first-line therapy recommended by the National Institute of Health, NICE, and other authorities as well for the management of heavy menstrual bleeding. Now, LNG delivers a low dose of levonorgestrel directly to the endometrium, suppressing the endometrial proliferation, thus reducing the menstrual flow. In obesity, complicated by multiple risk factors for cardiovascular disease, ischemic heart disease, stroke, and known dyslipidemia, the LNG-IUS is categorized as MEC category 2, and however, yet is this a good thing to use. The PROTECT trial, which looked at the acceptability of LNG-IUS in 25 women with class 3 obesity, identified a significant reduction in reported menstrual blood loss. There was a high level of acceptability, and it also promoted regression of atypical endometrial hyperplasia. Now, endometrial hyperplasia in obese, BMI of greater than 35 or more, it is suggested that 6-monthly endometrial biopsies to be done till the regression is there. Once 2 consecutive negative endometrial biopsies have been obtained, then also we have to put these women, because of the high risk of obesity, we should consider them for annual endometrial biopsies. This is for the atypical ones. Now, combined hormonal contraceptive. Now, CHC use in women with BMI 30 to 34 is rated by MSC as category 2, and this is upgraded to category 3 in those with BMI 35 kgs for mid-squat. So, there's a risk of venous thromboembolism, MI, stroke because of the exogenous estrogen contained in the CHC. A systematic review identified a 10-fold increase in VT risk in CSC users with obesity compared with normal BMI and not using the CSC. So this is something we can avoid in these patients. A transdermal patch has been found to be where the efficacy is impaired because of the weight itself. However, if the lady is using a combined vaginal ring, the efficacy is preserved even with elevated BMI. Now, progesterone only pill, it is rated as UKMEC 1 in patients with obesity. However, it is upgraded to 2 in presence of other risk factors of cardiovascular disease. Now, progesterones have been found to be as effective in obese than in non-obese patients. And we know that progesterone, though, may not be very, very good for the bleeding where LNG-IUS they supersede. But we do know that the women need to bleed at least 4 times or more per year. So for withdrawal bleeding, it is a good choice. So coming to dipomedroxyprogesterone acetate, it is rated as UKMSE1 in obesity. Now in women with obesity and additional cardiovascular risks such as hypertension, diabetes and smoking, it is categorized to category 3. There is some evidence of an association with DMPA use and weight gain, especially in the adolescent population. So it is useful in patients with obesity for management of HMB, but special caution needs where additional risk factors and in adolescents. Coming to the progesterone implants, which is just catching up in a big way, they function as hormonal contraceptive through triple modalities of suppression of ovulation, thickening of the cervical mucus, thinning of the endometrium. Now, this results in effective reduction of HMB. Thus, the implant can be offered with other progestins for management of HMB. And there is no evidence of weight gain secondary to the use of implant as against DMP. Now, ulipristal acetate is extremely effective in the treatment of HMB secondary to uterine fibroids with cessation of bleeding in 90% of those undergoing treatment within 7 days, along with a 50% reduction in fibroid volume within 3 months. And it is found to be effective in patients with obesity, but then we have to take into consideration all the, the riders that come with the use of ulipristal acetate. But in obese where surgery is contraindicated, this may be. Now, tranexamic acid, a study looking at 126 patients with obesity, they found that in the intraoperative transfusion rates were very much reduced with this use with obesity and morbid obese women, suggesting a good efficacy of tranexamic acid regardless of BMI. So, this also is in a kitty for these patients. Now, coming to the surgical management. Outpatient management carries less risk in patients with obesity. Outpatient hysteroscopy and operative hysteroscopic treatment modalities should be used wherever possible to avoid the risks associated with general anesthesia in obesity. If surgical management is required, practicality, safety, and preoperative assessments are essential in patients to minimize the risk of general anesthesia. Now, we had a good talk on uterine polyp. Larger polyps are associated with abnormal uterine bleeding in 13 to 50% cases, and these are generally unresponsive to progesterone stimulation. So, polypectomy is a good option, and especially if it is a hysteroscopic polypectomy, we know things are much better. Excision is curative as circumscribed foci of endometrial hyperplasia are in the polyp with no background hyperplasia. An interventional radiology procedure, the uterine artery embolism, has been, it is used for fibroids and is comparatively safe in obese patients as well. Now, endometrial ablation, we have to be a little cautious because we know obesity is a high risk for getting hyperplasia and atypical changes in cancer. So, we have to be judicious in our use. Endometrial assessment by hysteroscopy and biopsy should be taken. And there have been a greater failure rate in this method in these patients. Now, transcervical fibroid ablation, TFA, using the Sonata system, NICE recommends it as an excellent option in patients with obesity. So, hysterectomy may be considered in women who have completed childbearing, have failed other treatments, or a significant pathology, and it can increase the risk of complications with any surgical procedure. Laparoscopic hysterectomy, though technically challenging in patients, have lower risk of post-operative morbidity, and we should try to avoid abnormal as possible. So finally, concluding, obesity and all components syndrome impact AUB and related health issues, lifestyle changes, weight management should be addressed while treating AUB. Both medical and surgical management present unique challenges with obesity and require individualized approach. Additional consideration must be given to the risk associated with estrogen in obesity and outpatient management as much as possible and save the uterus. Here comes in our rescue. So thank you everyone for your patience.
Vanita, you are muted.
Yeah.
Vanita, unmute. Huh.
Okay, unmute.
Unmute, Vanita.
Yeah, or maybe Durga sir can just introduce our next speaker, Dr. Sarita ma'am.
Yeah.
Okay.
Dr. Mita, it was a
Hi.
yeah, it was a wonderful talk covering all the topics. I think metabolic syndrome always stands a difficult situation in AUB in the management, and I think LNG IUS has a better application in the case of comparing to the risk of obesity and other risk factors. Yeah, you covered everything, Meena. I think you may go ahead.
Thank you, Dr. Meena. Now I'll request Dr. Durga Shankar Das sir to kindly introduce Dr. Sarita
Introduce
Agarwal.
Dr. Sarita. Yes, Dr. Sarita Agarwal is a very well-known person in Foxy circles. She was the chairperson of HIV/AIDS when HIV/AIDS was a real threat to entire world, and she did a lot of workshops, lot of constructive work during that epoch. She was also the past Vice President of Foxy, and at present, she is head of the department AIMS Raipur. Not only that, she is the Dean Research. So this Dean Research adequately defines her credibility. Let us listen from her.
So thank you, Dr. Durga Shankar, for your kind word. I hope I am audible and my slides are visible.
Yes, Sarita, make it slideshow.
Make
Yeah.
it also here.
Slides. So this is slideshow visible?
Yes, yes, yes.
Now, yeah,
Okay.
yeah.
So at the outset, I must thank the ICOG officials, Dr. Lakshmi Srikhande with a special, Dr. Pratibha and Dr. Parag and all this, giving me this opportunity. Though I am a blackboard teacher, but I'll try to give justice to teach the PG students. So my talk is going to be more focused on something, what the clinical evaluation and management should be done. So my topic is very specific, management of acute abnormal uterine bleeding. The definition has been discussed. The key points here I want to mention what usually the PG makes a mistake. The FIGO directly says must be from the uterine corpus. It is not from the cervix and vagina. So AUB does not include the bleeding from cervix and vagina. Apart from that, heavier irregular cycle in between period, everything is included. And if she's in a pregnant, again, it is related to pregnancy, is not included in the abnormal uterine bleeding. So we have discussed about the palm coin classification by many. So if I talk about the acute and the chronic, I must be able to differentiate whether it is an acute AUB or chronic AUB. So any patient who is presenting with the bleeding per vaginum, as per the FIGO, the chronic AUB is told when the duration is patient is having the bleeding episodes may be regular, irregular for more than 6 months. Where when we talk about the acute AUB, it refers to the heavy menstrual bleeding or bleeding from the outside the normal cycle, which is sudden in onset. It's a gynecological emergency and can lead to hemodynamic instability and severe anemia. And if untreated, can be life-threatening. Therefore, it needs an acute attention and urgent intervention. So it is very important. One must understand if the patient comes with a heavy menstrual bleeding, it requires urgent attention because the presentation may be in the form of shock or maybe in the form of hypovolemic state and severely anemic patient. In that case, they need an urgent attention. So if I'm having a patient, say about 15 years old girl, who have come with a heavy menstrual bleeding, attended somewhere, given some management, they have given the blood transfusion, but the measure to arrest the bleeding has not been done, and the further workup for identify the etiology has not been done. So in such cases, it is very much important whenever you get such cases. So we take the history, we do the examination, we do the relevant investigation, but in urgent, acute onset, we don't have much time for all those things. But we need a short and sweet history which can tell us the point of toward the diagnosis so that the focused intervention can be done. So I must say the most common condition where we face there's an acute onset, acute bleeding is an anovulatory bleeding, usually in the adolescent girl and the perimenopausal women. Second is a coagulopathy. Again, we get in the women with in the girls in the pivotal age group, and then in the elderly women were mostly on some of the other anticoagulant therapy for some medical condition. Then another thing is an iatrogenic causes. The patient has had a history of IUCD insertion, or many times it happened they are in the hormone intake. So they go to some quacks or some peripheral doctor, they prescribe the progesterone. They take for 2-3 days, the bleeding is stopped, then they bleeding stops and they stop the medication. Because of that, the bleeding occurs. And then structural causes, of course, polyp, submucous fibroid, and malignancies usually have an acute onset of the bleeding. Then endocrinal disorders in the form of hypothyroidism, PCOS, and hyperprolactinemia. In the PCOS, usually we get that the patient has a prolonged period of amenorrhea followed by the heavy menstrual bleeding. And we miss this diagnosis. Then certain endometrial local pathology and the abnormal vascularization can be the one of the cause for heavy bleeding, like an AV malformation. So whenever the patient comes with an AV bleeding, then we must keep these causes in mind rather than having a description of the palm coin classification. Yes, you know that. But whenever you have an acute emergency, we have to do the common 1, 2, 3, 4 causes that makes the difference. So I'm describing this much of the things because whenever your patient comes in a acute bleeding, we have to take in a fast history. And this fast history should be in a focused history, so you can find out what is the etiology. Of course, when you are managing, you have the different goals. I will be talking in detail later on. So, and these differential diagnosis, if you look at the age of the patient, then also you can make it out. Because we have the different causes for the adolescent, the puberty age, perimenopause, and the postmenopause. And these have been very well covered with the previous speakers, defining which are the common conditions in sub-age group. So when we talk about the management of acute AUB, the goals are that the first thing is achieve the hemodynamic stability if the patient is hemodynamic unstable. So you look for the pulse, blood pressure, and the pannel status. If it's unstable, the first thing is to manage the hemodynamic instability, achieve the hemodynamic stability, and it's something like a preliminary management of shock-like condition. Then the second step is arrest of the bleeding. Third step is correcting the anemia. And fourth is an identify the etiology and go for the definitive management and then the follow-up. So if I want to achieve these management goals, we have to follow these 10 steps. I'm going to take these 10 steps one by one, not wasting time on reading these 10 steps here. So coming to the first step, that's the initial assessment and stabilization. So initial assessment should include the hemodynamic stability status first. Second is the severity of the anemia. That is by the clinical judgment. You can't wait for the blood reports to come. Third, whether the active bleeding is present at now or it is being arrested. Then in any case, whether married, whether unmarried, perimenopausal, whether tubal ligation done or not, in all cases, the first thing you should rule out the pregnancy. Then of course, many times we get that trauma and there is a history of bleeding from other side. These are the things which we should look for evaluation, because if you get a history of bleeding from other sides, your intervention may be a little bit different. Then you go for the identifying the underlying etiology. That is by the clinical history, examination, and the review of her previous record. Most of the time we do the mistake, we don't ask for whatever the workup has done in the past, what medication she has received in the past. It's again very important to review her records, because you don't have time to wait for your investigation as of now. The first thing you have to address if she is hemodynamic unstable. So hemodynamic unstable, I already told that this is like a management of shock that achieve airway, breathing, circulation, look for vital signs, establish IV exercise, start blood transfusions. And for that, of course, you need the blood for the cross matching. And if the hemoglobin is less than 7 gram or the patient is having hypotension, that case the blood transfusion should be, packed cells should be started as early as possible. Sometimes you need this fresh frozen plasma and platelet and cryo if you are aware through the record that she is a case of coagulopathy, or if she is receiving the multiple transfusion, then again now the concept is a 1:1:1 ratio. So you may require to keep the supplement FFP, platelet, and cryo. Then of course the urine output monitoring may be important if the patient is hemodynamically unstable. Coming to the second step, that is again very vital, you need to arrest the bleeding. So to achieving the arrest of the bleeding, we have the various measures. It has been discussed in the various way, and the doses will be discussed. So hormonal therapy, of course, you have to rule out if there is an absolute contraindication of the hormone. The best agent to control the bleeding is an oral contraceptive pills in the high doses. So this is, maybe you can do, it's not like a one pill once a day. You have to give one pill thrice a day. And that can be continued for 5 to 7 days till the bleeding is stopped. Then you can maintain gradually by tapering gradually. If you start with TDS, make it BD, then make it OD. Then high dose progesterone. When you're preferring the progesterone, we know that the androgenicity of the progesterone decides this hemostatic property. So higher the androgenic activity of the progesterone, it arrests the bleeding better. So on that, you have the norethindrone and the medroxyprogesterone acetate. Again, you start with a higher dose, 30 milligram per day in divided doses, then gradually taper in. And it is very important when you are giving the hormones, arrest of bleeding, the patient should be counseled that they should not stop the hormone pill once the bleeding is stopped. And then about the estrogen, only estrogen injections were available, which can be used, but this is not the first line choice. If you fail to arrest the bleeding with the progesterone or the OCPs, in that case, you can use the injectable estrogen, but this estrogen should always be followed by the progesterone and then it should be stopped. Because if you give the injection estrogen, the bleeding is stopped, and that it can be the torrential bleeding, because of the estrogen withdrawal should always be supported, followed by the progesterone. About the antifibrinolytic, tranexamic acid, then NSAIDs. This is again important because it has been discussed in the previous lectures. I'm not taking the detail which and what doses. This can be started simultaneously, hormones plus antifibrinolytics plus NSAID. So all these three can be started together to arrest the bleeding. But of course, based upon the need, you can decide either 3 is required, 1 is required, or 2 is required. Then if the bleeding is not able to be arrested with this medication, then you have to look for the escalating the management option. I'll be taking this escalation in the subsequent slides. Then coming again, most important, the woman is on any of the anticoagulant therapy, you stop this first. And many a times we need the injection, vitamin K injection also to be given those who are on the anticoagulant therapy and the coagulation profile is disturbed on this patient. You can give for the this injection vitamin K to this women. The next step is a monitor and reassess. So you have given the hemodynamic, the blood transfusion and the IV fluid hemodynamic stability is achieved. But maybe question that all the patients are not hemodynamically unstable. On such condition, you can skip the first step of the management of IV fluid and all. But of course, most women are severely anemic. They do need the blood transfusion. So you given the medication for the arrest of the bleeding. You are given the blood transfusion. So this patient is under regular monitoring, and then monitoring is on the term of whether the hemodynamic stability is achieved or not, and the bleeding is controlled or not. So usually we look that the bleeding should be controlled within 24 to 48 hours. If not, then we have to proceed for the next step. And this next step is you have to evaluate again. And this evaluation includes now the detailed history. That is, a focus history taking is very important. I said the focus history can be taken only when you have certain things in your mind. Okay, what could be the etiology for that? So like if you look for the focus history, of course, you have to ask for the this last menstrual period, the cycle, because amenorrhea followed by bleeding PV, or she has a regular cycle, or she has an intermenstrual bleeding. So it's like an anovulation of PCOS. Usually you get in a period of amenorrhea followed by bleeding pulvaginum. Then the medication history, anticoagulants and hormone intake. Bleeding disorders, again, very important. The bleeding disorder should be ruled out by the personal and the family history, bleeding from the other sides, or having the ecchymotic patches. And then you have to look for the systemic illness like thyroid, liver disease, and renal disease, because these are the conditions which can be affected with the hemostatic mechanism without any organic pathology in the uterus itself. The bleeding can be there. The detailed clinical examination, general systolic examination should be performed. The TVS becomes the, is it the signal for the time over?
Yes, ma'am,
Yes,
the
yes.
time is over. You can just
I'm
take
just taking
2
another
minutes.
2 minutes. Step
Yes.
5 is a detailed clinical examination has to be performed to find out the etiology. And the per-rectal exam is important if it is an unmarried girl. Coming to the TVS and the laboratory work, this has already been dealt previously. So TVS is a very much vital if it is a married and the sexually active. And the laboratory worker, the coagulation profile is must, thyroid function is must, LFT, RFT if indicated, and iron profile and HPLC is important because we are giving the blood transfusion. We do not want to harm the patient. Then about the escalating the management, that we have the escalating the management can be the medical management can be added further, or intrauterine balloon tamponade with the Foley's catheter. We have managed 2 or 3 patients by putting this when the anticoagulant therapy women got. DNC therapeutic curettage definitely helps a lot in the women, the perimenopausal women and the reproductive age group. Hysteroscopy with structural abnormalities been identified. Uterine artery embolization has a role in the fibroids which are bleeding, and arrest of bleeding can be obtained. And of course, the endometrial ablation and hysterectomy are the definitive. Other management, desmopressin, intranasal, intravenous, and AV with the coagulation disorders. And then the other specific factors, factor 8, Willebrand factor, when you think it is a coagulation disorder. Then anemia correction is again vital. The giving blood transfusion is not sufficient. She has to be given further IV iron therapy and the folate and the nutrition. Then plan and treat the underlying causes. So based upon this, you identify the etiology. Plan and management has to be very much find out. And then the etiology identified should be managed in a proper way. It has been discussed. Then discharge planning is very, very important. Once we arrange the breathing, you cannot discharge the patient like this only. At that time, you have to inform them hormonal therapy continuation, adherence to the maintenance therapy, iron supplementation, follow-up ultrasound biopsy, and what definitive plan you have planned for this patient has to be very well told about. So this is all the steps of management. And then conclusion, the management is an emergency. Stepwise approach is always good. So we have to follow this step. Thank you very much.
Okay, thank you. Even if you give a one-line conclusion, I'll say, even if it isn't acute, take a brief, focused history and review the rule-out pregnancy and review the previous medical records so that immediately to conclude some etiology behind it. Okay, let us proceed because we have already become defaulted. Time is running out. Okay, over to Lakshmi.
Great, great.
Thank you.
Sarita,
Thank you.
full justice to the topic.
Yeah. And there is
So-
one questions in the chat box you can answer. Thank you, Dr. Sarita.
Is there any question? I cannot see the chat box here.
Yeah, Aditi, let's go ahead with the next question. Yeah.
So
Yeah,
moving
Aditi.
over to session 3, we will be starting a panel discussion on case-based scenarios in AUB. First, I would like to introduce, should I share the CV? If you can stop sharing the screen, Dr. Sarita.
Yeah, Sarita.
Thank you.
So I would like to introduce an expert on this panel. It's my honor and privilege to introduce Professor Dr. Suchitra Pandit, ma'am, who has been the Foxy representative to Suffolk, past president of Foxy. She's also an
Just keep
associate
it short
member of
because we have got we're already running short of time.
Yes, ma'am. Figo Ethics Committee. So welcome, ma'am. It's a privilege to have you here. I would like to introduce our esteemed moderators, Dr. Anju Soni, ma'am, who is the president of IMS and past Secretary General of IMS. Dr. Munjal Pandya, who is the president-elect of Ahmedabad OBGY Society and associate professor at Narendra Modi Medical College at Ahmedabad. I'm introducing our esteemed panelists. First is Dr. Jyoti Malik, ma'am, from who is a medical superintendent at JJ Institute of Medical Sciences, the vice chairperson of Haryana chapter of ISAR. I welcome you, ma'am. Dr. Kavita Bhati, ma'am, who is the professor at Department of OBGY in CMC Hospital, Ludhiana. She has been the vice president of Ludhiana OBGY Society and president of Ludhiana Menopause Society. Dr. Shaili Agarwal, ma'am, from Kanpur. She is a professor in OBGY at GSVM Medical College and secretary of Kanpur Menopause Society and scientific secretary of Kanpur OBGY Society 2023-2025. Welcome, madam. Dr. Shweta Kaul Jha from Indore. She is a managing committee member of ISAR and joint librarian of MP ISAR and managing committee of MP IAG as well. Dr. Professor Sudha Prasad, ma'am, who has been the past president of IFS, vice president of Foxy, and past president of AOGD, with so many years of experience as a teacher. Welcome, ma'am. It's our honor to have you here as a panelist. Dr. Sujal Munshi, sir, he is the General Secretary of IIG and a well-renowned laparoscopic surgeon from Ahmedabad. Welcome, sir. Professor Uma Pandey, ma'am, she is the professor at Department of OBGY, Banaras Hindu University and former HOD of Banaras Hindu University. She has been a co-opted representative at AICC RCOG North Zone 2024 and a past president of VOGS. Welcome, madam, to this panel. Dr. V. Radha Lakshmi, who is professor in Department of OBGY in SRMC Nandyal and secretary of Kurnool OBGY Society. Welcome, ma'am. So these are the esteemed panelists. The panel is going to be of 45 minutes. So our esteemed moderators will
Can I share my screen, please?
Yes,
yes,
please.
madam. You can go ahead. Yeah.
Are my slides visible?
Yes, coming. They are coming.
They're loading, ma'am. Yeah.
Thank
They're
you.
visible now, ma'am.
Can everybody see the slides?
Yeah, yeah. Yeah,
Yes.
Jyoti.
Yes, ma'am.
Thank you so much. Thank you so much. So at the offset, I would like to thank the ICOG team, Dr. Parag Binewala, Dr. Sarita Bhalerao, and Dr. Lakshmi
Just a
Shrikande, who
minute,
has
can support unmute Dr. Munjal Pandya?
Done, ma'am. Done, ma'am. Thank you. Thank you, ma'am.
Yeah, so I would like to thank all everybody who is there, the conveners, for organizing this marathon workshop of 3 days. And I have been through and through in this workshop, and I can tell you that you have gone through the best of the faculties in last 3 days, and they have covered almost each and everything. And we will be just revising with all the experts, and I'm privileged to have Dr. Suchitra Pandit. I'm sure you will get a lot of good messages from madam, experts, as well as the panelists. So whenever we talk of AOB, it is in the perimenopause, because other things have been covered in the previous panel. So we are going to talk about perimenopause and postmenopause. So it is a ovulatory bleeding. It may be heavy and it can be associated with that there are multiple consequences for the woman, from patient to family to economics. And we all know, we have been going through hearing this FIGO classification, which has been revised in 2018, which covers the palm and coin. It is basically a simplified and unified terminology. It allows a clear focus on the treatment concepts, facilitates clinical and scientific research. It also provides the basis for to structure more effective clinical teaching, and it serves as to enhance and clarify communication within and between the specialties, so that all can speak the same language. So when we talk of palm coin, it is basically the reality is, it is structural versus non-structural, which as clinicians means to me that operative hysteroscopy versus hormonal or expected treatment. So our patients feel that the blood that comes out through your vagina is the period, but we all know that any bleeding that proceeds 2 weeks before ovulation or on sequential MHT is known as menstruation. Erratic function of ovaries in late perimenopause often makes it difficult to label bleeding as definitely postmenopausal. So when we talk of the etiology, we all know that from hormonal to benign anatomic changes to cancer, there are different aspects available. So we'll start with the first case. Mrs. N, she's 48 years. She's a homemaker, gravida 3, para 3. Her last child birth was 20 years. She complains of irregular heavy menstrual bleeding for last 10 months. She presents with the history of present illnesses. She had previous regular cycles. Now the cycles every 20 to 45 days. Bleeding is prolonged for more than 10 days with clots and is associated with fatigue and mild shortness of breath. There is no past history of any chronic illness, and she is not on hormones. And her mother had menopause at the age of 50, and there is no family history of malignancy. And when we talk of diagnosis, the goal of diagnosis is to distinguish the woman with anatomical cause from woman from normal anatomy, and identifying endometrial malignancy, although uncommon among AUB etiologies, it is often main purpose of the investigations. And the assessment of abnormal uterine bleeding starts with the general assessment, laboratory test, and evaluate the pelvic organ, especially through ultrasound, hysteroscopy, and MRI. So, Dr. Jyoti, how will you proceed for examination of this period? Dr. Jyoti, are you there?
Not joined yet, ma'am.
Anybody can take this question. Dr. Sudha, you can take this question.
Oh, yes. She's a 45 years old patient, so we should examine her first. And from the hemoglobin, how much is she, whatever history she's giving, is she really anemic or that? And per-abdominal examination is must. That is she having some fibroid or some other problem is associated. It can be adenomyosis, it can be a fibroid, it can be endometriosis or any mass or pelvic inflammatory disease of that. And PS examination and the PV examination, which is a forgotten maneuver. In today's date, everybody does the ultrasonography and just put the probe on the abdomen. So PS has to be done. There may be some hanging polyp, simply, many times I have taken out in ultrasound, nothing, everything is fine. And polyp is hanging in the vagina and just you twist and take out and the bleeding is over. So this may be the possibility, and one should do the bimanual examination always. That has to be seen, that how the mobility of the uterus, how big the uterus is, and irregular mass, if it is a fibroid, or it can be simple ectopic also. One should not forget, it can be ectopic, that one unilateral mass is
Madam,
there.
we'll go for investigation for that.
Acha, okay. So what I want, the clinical history plus the physical examination has to be done in this.
Thank you, ma'am. Thank you. So, Dr. Kavita, are you there?
Yes, yes, I'm here.
Yeah. So, what are the investigations you will do in this patient?
So, ma'am, first and foremost, even though she's 48 years old, she's been menstruating, so we need to rule out pregnancy and complications as pertaining to pregnancy, like ectopic pregnancy also. So after ruling out pregnancy, then we'll go for the basic investigations like a complete blood count and thyroid function test, prolactin only if it is indicated. And since you have said there are no comorbidities like diabetes and hypertension, so we need not go into those investigations, but an ultrasound will be required, preferably a transvaginal ultrasound. But before we go on for ultrasound, a pap smear also should be done, because if she's not bleeding, especially because we need to rule out CIN or cervical intraepithelial neoplasia and all. And transvaginal ultrasound will help us in detecting any fibroids, polyps, look at the endometrial thickness also. It could be endometrial hyperplasia. And if transvaginal ultrasound should always be along with the trans-abdominal scan as well. And once we have done the ultrasound to look at the uterus and the adnexia, look at the ovaries, then we need to do a endometrial sampling. So in the office setup, we can do a pimple, or if you want to do
We'll go further. Thank you. Thank you, Dr. Kavita. We'll go further. So what are the techniques of imaging? Dr. Radha Lakshmi?
Yeah. The first thing is the trans-abdominal, followed by transvaginal ultrasound to be done. If possible, we have to do 3D ultrasonography and also color Doppler also when you suspect adenomyosis bar fibroid and malignancy, because she is in a perimenopausal age group, if you suspect malignancy. So first, most of the times I do trans-abdominal followed by transvaginal. Then I'll go for 3D ultrasound with color Doppler.
What about SIS?
So if you suspect any endometrial pathology, if you are not having 3D ultrasonography, then only we go for SIS. If good with the 3D ultrasound, most of the times we don't need SIS.
What about MRI?
So MRI only for fibroid mapping, madam. So to know I think first we should do the endometrial curettage and the cervical canal curettage to rule out the pathology, and then only we should put the fluid inside the uterine cavity. Otherwise, it will disseminate if we are thinking of endometrial carcinoma or something.
No, madam. No, madam. I will not agree with you. We'll take the opinion of experts later. But I don't think this is any possibility of any kind of spread. Even hysteroscopy you can do easily. There is no risk of spread of
migration of malignancy.
Yeah, that is very, very clear. So we are talking of imaging at the time, but we'll go to the next.
Okay.
So in this patient, the findings were her hemoglobin was 9.2. She was UPT negative. Her endometrial thickness was 8. There was small intramural fibroid. Otherwise, there was nothing else. Biopsy taken showed proliferative, no atypia. And one thing which I want to point out here, which is very, very important, is that when the endometrium is less than 4, the risk of malignancy is less than 1 in 917. And also, there is a consistently finding of thin endometrium less than 4 to 5, which was shown to be effectively exclude the significant tissue in postmenopausal bleeding also. So this is a very huge study done where they showed a lot of cases were seen from all the studies where they showed whenever the endometrium was less then 4 to 5, the negative predictive value for these cases was very high for malignancy. So they were saying, they said that we can easily rule out malignancy in these patients. So what are the indication for endometrial sampling? Dr. Shelley, are you there?
Yes, ma'am, I am here.
Yeah.
Am I audible?
Yeah.
Your voice is too low.
Okay, ma'am. Is it clear now?
Yeah, still low.
Okay. So, if the age is more than 40 years and patient is having the history of abnormal uterine bleeding, she should be taken for the endometrial sampling in all the cases. But if she is less than 40 years and if she is a high risk for endometrial cancer, like she has obesity, she has diabetes mellitus, or she is having family history of cancers or hereditary cancer, then the sampling is must in all these cases.
Yes, you have said very perfectly that even the IMS in they have brought out this white paper. They said that endometrial sampling is very essential to diagnose any abnormality, and this can be done with after an ultrasound or hysteroscopy with disposable suction catheter. However, there is relatively high incidence of false negative result with this office hysteroscopy, which you said, and the cancer may be missed. So, recurrent bleeding will need further evaluation, and thus high overall accuracy in diagnosing endometrial cancer depends on the adequate specimen. And most important role of to diagnose is the malignancy, and also the status of endometrium helps to plan the treatment. And no existing method samples entire cavity, and sensitivity and specificity is very variable. There is also a proof that absence of malignancy cannot be completely say yes, and pathologists can only diagnose what they see on their slides. So as per the guidelines of ACOG as well as RCOG, they also say that in these women, when a patient comes after the age of 40 or in a perimenopausal stage and her endometrial thickness is more than 12, then we must take an endometrial biopsy, and sensitivity of this for carcinoma endometrial for this office endometrial biopsy is only 67 to 96. And there all the reviews when they compared, they with different sampling, they found that the accuracy was there, but it was less, and negative predictive value was more when when the patient was cancerous, it was there. So initial biopsy negative and patient persists, we have to look into the patient once again. So what are the sampling devices available? Dr. Shweta, are you there? Dr. Shweta?
I think she's not there now.
So anybody can take it.
So endometrial sampling can be done with the pipella, madam, most of the times. And we can get 85% results with the pipella. And also we can do vacuum aspiration with Vibra aspiration device. So if both of them are 85% accurate in diagnosis of endometrial pathology. So we don't advise nowadays dilatation in curettage because the detection rate is only 65% compared with the pipella. So in both the cases, if it is not possible to receive adequate amount of sampling in spite of the thickened endometrium on hysteroscopy, we can go for hysteroscopy.
So what are the pitfalls of people endometrial sampling, Dr. Kavita?
First of all, there are certain advantages with the people because it can be done as an
Advantages we have
OPD.
heard. I want to know the pitfalls.
The pitfalls are that it can miss some of the pathology, and you cannot get sometimes in adequate endometrial sampling. And some of the other pathologies like tumors or polyps can be missed with the people. And occasionally you cannot negotiate also beyond the internal loss.
In cervical stenosis, is that?
Yeah, yes. So as per the guidelines, they said that there was, if the area of involvement is less, then we will miss the diagnosis. That is the most important part, and that is what is we must always keep in mind, because when they look, a lot of people, when they did different studies from people and from the sampler, they found that they missed quite a many number of cancers. So the false negative rate has been very high, and if the cancer occupies less than 50% of the surface of endometrial cavity, then it can be missed by this endometrial biopsy. And also endometrial biopsy has a high overall accuracy in diagnosis when adequate specimen is obtained and when the endometrial process is global. But a positive test result is more accurate for ruling out disease than the negative test for ruling it out. And these tests are only an endpoint when they are reveal cancer or atypical complex hyperplasia. Now that the standard of care acknowledges that the blind biopsy is not always a stopping point, and clinician can still begin with the biopsy, but with persistent unless it is malignant, like complex atypical hyperplasia or endometrial evolution is not complete. So is hysteroscopy superior to DNC and AB, Dr. Shaili?
Yes, ma'am, definitely. With hysteroscopy, we can visualize the endometrial cavity. If there is any abnormal area, we can take the targeted biopsy from there. And sensitivity of the sample is also increased with the hysteroscopy guided biopsy.
Yes. What about diagnosis? It is you can always
Yes,
do
ma'am,
diagnosis as well as therapeutic in one
yes,
sitting.
in same sitting, we can also do the polypectomy if there are any polyp, or if there are any submucous myoma, we can do the myomectomy also. So it can be diagnostic as well as a therapeutic in the same setting.
So
And you
these are
can
the
directly
latest guidelines.
visualize and take the biopsy of that place if
Yes,
Yes,
the
absolutely.
lesion is very small.
That is why we call it a gold standard, because
Yes.
you can take out the sample from the affected area. You can see and take the sample, and that will really help in, especially in cases of endometrial hyperplasia, because in some places you can see the hyperplasia, so you can always see the particular point and take it. So it is a gold standard. And now since we have thinner scopes available and can be done it is done by at outpatient setup. There is no need to do cervical dilatation, and you can do through vaginoscopic approach, and there is no need of speculum, tenuculum. Vagina is distended and there is a decreased patient discomfort. So that is what is required. So when to perform hysteroscopy, Dr. Sudha?
When the bleeding is not there, then ideal situation is that we should perform in that, not in the secretory phase when the thickness is very high. If you really want to see, I will prefer in the proliferative phase when the bleeding is stopped.
So what are the contraindication to hysteroscopy? Dr. Sujal is not there, I believe.
No, no, ma'am. He's not there.
I'm here. I'm here.
Anybody?
Acha, Sujal bhai is here.
he's-
No, no, Sujal bhai is
he-
here. Here.
He's
Yes.
very
So
much
can you
there.
take this, please?
Yes. So unless the medical condition is not allowing anesthesia, but nowadays we do it under without anesthesia under paracervical block also. When we use a 1.9 mm telescope, the dilatation is hardly required. So in office setting, even with comorbidities, medical comorbidities, you can always do it. In suspected pregnancy, usually we try and avoid. In cases of severe infection, but yes, in cases of pyometra with low this thing also, we have been doing it. You have to keep the intrauterine pressure less than 80 mmHg whenever you are suspecting infection. So when you keep it below 80 mm, the osteas are not going to get opened up, and you will not have any spill of the fluid inside the peritoneal cavity. So even in cases of suspected this thing, but preferably it should be avoided. And you can use very good sanitization before doing it. And any history of uterine perforation, that was a previous contraindication. Now in case of previous perforation also, very safely with low pressure you can visualize the uterine cavity. So that is also not a
We are only talking of the recent, not the old perforation.
Yes, yes. So
thank you so much for
it's a
pointing out this very important takeaway, that the pressure should be less in these patients, which is very, very important point you have given to everybody present
unless
here.
medical condition does not take, there is no absolute contraindication. No.
Yes.
And
So what is
Sujal
the
bhai, Sorry, yeah, just a single question. Will there be any, change with regards to the usage of distension medium with
Yes.
regards to this particular condition?
So nowadays, when you don't want to use any electrocauteria, electrolyte media is preferred because most of these patients are above 45 or 50. So try and avoid using electrolyte free media. Use normal saline or ringer lactate only. So a slight volume overload will not have any effect.
Yeah, sure. Thank you. Yes, ma'am. Anju, ma'am.
So, what is the effect of tamoxifen on endometrium? Dr. Radha?
Yeah, madam. It increases the endometrial thickness, especially if it is used for a longer period of time. And it is more significant, it is more than 8 millimeters, especially in breast cancer patients. We must be vigilant while using tamoxifen, madam. So if the endometrial thickness is more than 8 millimeters, we have to do endometrial sampling to exclude the possibility of endometrial hyperplasia with or without ETPR. So
Yeah, when you do an ultrasound, you can see this echogenic thickened endometrium, and when you do the hysteroscopy, you will find the pseudo polyps in the cavity like this.
Yes.
And this is a biopsy of that pseudo polyp, where you can see cystic areas in these polyps. So we must keep in mind whenever a patient is on tamoxifen, what we are looking for, and what we must tell the patient about it. So, what is the treatment of AOB in non-structural causes that is coined, Dr. Shelley?
Unmute. Unmute, madam. Shaili, madam, unmute.
Yes, ma'am. In the non-structural causes like coin, the first resort is as the tranexamic acid, and NSAIDs we can use, or if the cases of anovulatory infertility, then we can use the progesterone to stabilize the endometrium, and LNG-IUS can be used accordingly. So basically, the treatment is medical management in such cases.
Yeah, absolutely. It is a medical management. But one thing which I want to point out here is that awareness, reassurance, and keeping healthy lifestyle is also very important treatment option. We must always look into that, because just before our panel there was a lecture on obesity. So these are the patients who will come to us. So we must bring in the awareness in those patients. And as you have very well said, that there is non-hormonal as well as the hormonal types both available. And then of course the surgical part of it, which will come later. So
we should not forget that AUV can be due to the thyroid dysfunction also.
Yeah, that is why, madam, if you remember, we did TFT in this patient, thyroid function test.
Thyroid function.
Yes.
Right.
So the when we are talking of treatment of AUB, we all know that we have to talk about coin as well as palm. So as we have already in this patient seen that we have to treat her coin problem. So pharmacological treatment will be the first line treatment for this, and for that we will be giving hormonal, as you have already said, and non-hormonal both. So how many types of progesterones are there, and how should Jyoti Malik has raised the
Ma'am,
hand.
sorry to
Jyoti.
interrupt. Ma'am,
Yeah, Jyoti,
Dr.
bolo,
Malik
bolo,
has
bolo.
joined us. Yeah.
हाँ Jyoti.
Ma'am, you can start your video and unmute yourself, Dr. Jyoti.
Dr. Jyoti is there, I think.
Yes. Yeah, she has been made the co-host now, ma'am. So you can start your video and.
By the time she is joining, Dr. Shaili, can you tell how many types of progesterones are available?
Yes,
And
ma'am.
how are we using them?
We have northestrone, that is the hemostatic property also. We have the methoxyprogesterone acetate. We have the newer estrogens like newer progesterone, like micronized progesterone, and we are also having the LNG-IUS. So they are the various methods of administration are also available. They can be injectable, like DIMPA. They can be oral, and they can be intrauterine also.
So how do they act?
They are promoting the endometrial atrophy, and they also stabilize the endometrium, which is due to unopposed estrogen, and also they cause the anti-inflammatory action on the endometrium. And basically, they promote the amenorrhea. Yes,
yes,
in the long term. In the long term.
So should we use it as cyclic or continuous? What are the advantages of that?
Depending on the scenario, ma'am, we can use, like she's having annullatory bleeding and she wants she wants her periods. So we can give cyclical also. If she is a case of endometrial hyperplasia, then we have to give the continuous also for 3 to 6 months.
So different preparations are available.
Yes,
and we all know that micronized progesterone is preferred choice, but different preparations are available. And how do we administer them?
Yes, ma'am. To arrest the hemorrhage, basically, northestrone is having hemostatic properties also. So it is said to be given in higher doses, like 20 to 30 milligram daily to arrest the bleeding. And then after the bleeding is stopped, we can lower the dose for 21 days. And she should be emphasized to regular use of the hormone because many a time patient discontinue hormone and then she comes back with the bleeding.
So counseling is very important.
Counseling is very important. She has to complete the course.
Yes.
And sometimes when there is a corpus luteal insufficiency in luteal phase or with the presenting symptom is premenstrual spotting, then we can give in the luteal phase support, like from day 15 to day 25. Yes, ma'am.
And one more thing is that in the cases where there is a atypical hyperplasia, then in those cases we need to use a potent progesterone like norethistron daily or medroxyprogesterone.
If ma'am, family is complete, we should emphasis on the surgical management because the patient are lost and follow many a times.
No.
If it is ATP case,
we will take the opinion of expert. I am keeping everything in mind. We'll take their opinion later.
Yes, ma'am.
So, what about injectable progesterone?
Yes, some injectable progesterone are also available in the form of Depo-Provera. So they can be used. They induce amenorrhea.
But there are few studies available, and so we do not know.
And sometimes they cause them breakthrough bleeding, spotting a whole the month. So patient is very not unhappy.
There is intermenstrual bleed.
Yes, ma'am.
Yes, and also there are symptom of what fluid retention. So we do not prefer injectable. Depo-Provera is not preferred, but implants are of course can be given. What about LNG IUS? Dr. Sudha, can you take this? Dr. Sudha?
Yeah. So and this is the best treatment in today's date if we have ruled out all atypical cells of the uterine cavity, and we put a lot in these patients and they are very happy. It is a levonorgestrel. It is a 52 milligram for 5 years. It dispersed and it gives a very good relief because it decreases it is thin out the endometrium, and it works very well. Some patients are definitely are not comfortable, as they are not comfortable with the copper tea even, that something is inside, and some foreign body. It takes little time. In the first cycle, it have little intermenstrual, and after that it sets and it gives a better result for this.
What about irregular bleeding that can happen for 6 months? How do you manage that?
So number one, you have to really counsel a patient who was bleeding a lot. She will get the relief that now it is very minimal, and she can take the tranexamic acid or something side symptomatic treatment during that period.
Is there any correlation, ma'am, between ultrasonography and
Yes, can I
hello?
Yes. Can I add something?
Yes, Urjit.
Yes, first 3 months, we have to counsel the patient. Counseling of the patient in case of LNGIU is very important because it is very low dose. It takes 3 to 6 months for body to adapt to a sustained level of progestin. So till then, you can give ormelexicillin once or twice a week. Works wonderfully well. You can give tranexamic acid, and sometimes you have to add OC pills or progestins to cover that 3 months. By the time after 3 to 6 months, usually the support is not required.
Yes.
This was a very important point which I wanted to bring out because it is very important for us to counsel and tell these patients about what they are going to face and how will we, and if it happens, how will we manage. How many can anybody tell about how many micrograms of progesterones are released, and what there is a reduction, as you have said, by 71 to 96%, and there is definitely improvement in quality of life, and it is As Dr. Sudha said, it's very well accepted by the patient and it gives a prolonged relief. And advantages, you have already said, highly effective long-term subsequent hysterectomy is not needed. It is the side effects are less. Contraceptive efficacy is also there, and there is no operative anesthetic hazard. And it is an outpatient procedure, and there is decrease in dysmenorrhea and PMS also. There is also low complication rate. So, what are the problems faced with LND IUS, Dr. Sudha? I think this has come back to you again. You're muted.
If the LNG is put, number one, we said very well that there will be the bleeding, irregular bleeding, spotting will be there, effect will be less on the bleeding control. And as it is a progesterone, so effect of progesterone will be there definitely, like a edema or a intermenstrual weight gain kind of thing. It will be there. And more important is that the when we see the when we do the ultrasound, chances are there that it can be have the cyst formation. That is one which I have seen in many patients about it.
So what
So,
about
ma'am,
expulsion?
yeah,
Yes,
and
yes, Dr. Sujal.
yeah, ma'am, just wanted to ask one thing. Whether you would like to do a little bit of curating in case of endometrial hyperplasia before putting LNG IUS? If yes, then why? And if not, then why not? Yes, ma'am.
See, we have done the endometrial aspiration. We have ruled out atypia. There is no need of doing the dilatation and curettage. Once you do the curettage, once upon a time in 50 years ago, when we used to do the curettage and we used to say it is therapeutic, but now the thing is not there. LNG works very well. Even the hyperplasia is there. You have to follow up. So the patient should be counseled properly, that it should be followed up, and you have to keep an eye on her.
Yeah,
Dr.
thank you.
Sujal
Thank you.
wanted to say something. Dr. Sujal?
Yes, but when you do hysteroscopy and if you remove the thick endometrium, the effect of LNGIUI starts little early and irregular shedding will go down substantially. So emptying the cavity has an essential role.
Plus, what would be the role in case of anything that would distort the uterine cavity, as in submucous fibroid or even, yeah.
If UCL is more than 9 centimeters, if there is a cavity distorting myoma, IUS is not the ideal choice. So
It
in
is
that
not the
case, you have
ideal
to
choice.
it works very well in a correct cavity of some size. So anything above 9 centimeters, somehow it doesn't work. So if you look at the marking also on LNG-IUS, even if it is larger, they don't give markings beyond 10 centimeters. So it is not recommended
Yes.
for cases
So
above
I
that.
would like you to talk little about expulsion.
So for expulsion, you have to explain the chances of expulsion is highest in first 3 months after the insertion. So what we routinely follow is after 1 week, after 3 months, we do a sonography. If it is 1.5 to 2 centimeters below the fundus, it hardly matters as far as the whole stem is inside the uterus. The thread, you may revise and do a little cutting if it is slightly displaced. But if the stem is in the cervix, patient will have irregular bleeding. In that case, by a few companies, there is a policy that if you return the expelled LNG IUS, they will return free of cost and it should be counseled to the patient very well in advance. But if it has come out, preferably don't use the expelled LNG IUS, always replace it with a fresh one. So first week, 3 months and 1 year are very essential sonographies in post-operative.
Absolutely. This is what I wanted to point out, that the counseling of the patient is very important when you put in an LNGIUS, because, I have found a lot of patients who have been inserted with the ICT, they just disappear forever. So we must counsel them, and then they come with either pregnancy and other things. So we must counsel them that they have to come for regular checkup, especially in the first 3 months and later after 6 months.
And madam,
What is
on
the role of
sonography, yes, on sonography, sometimes it is very difficult to identify the LNG IUS. So sonography, or sometimes you just have to follow the shadow. That counseling is to be done to the doctor, whoever is doing the sonography. You will not see a ecogenic area.
Clear lines, yeah.
like property?
Yes, yes.
So what is the role of oral contraceptive pills? Anybody can take this.
So oral contraceptives can be used during acute episode. 2 tablets TAD for about 5 to 7 days, followed by 1 BD for another 21 days during acute episode. And the COCs are the drug of choice in adenomyosis, especially in the young ladies, especially if they don't want to have LNG UCDs also. And ovulatory causes also, you have to give combined oral contraceptive pills. And when there is endometrial pathology also, you have to give these oral contraceptive pills, but you have to exclude the other comorbidities like diabetes, hypertension, hypercholesteremia, and other any estrogen dependent problems.
Absolutely, absolutely. It has been found that combined pills reduce the blood loss up to 35 to 72%, and they are therapeutic cases where there is no structural cause. And literature says that it is seen given in a higher dose of 30 micrograms, and the continuous regimen has also been given in a cyclic or combined formulation. And as you said, it is contraindicated for migraine, smoking, and other comorbidities and thrombophilia. And how does it act?
So the combined oral contraceptives acts by negative feedback effect on the hypothalamus pituitary axis, thereby decrease the release of estrogen and progesterone and stabilization of the endometrium. So it decreases again by negative feedback effect, the reduced levels of estrogen will cause the decreased endometrial hyperplasia.
For acute control, ma'am, you mentioned oral contraceptive pills. There is one component known as equivalent, kind of testosterone. Has anybody used it for acute stoppage of bleeding in case of menorrhagia?
No, I have no idea.
Okay.
It is the testosterone. Equivera, I have used it. And now I think it is not available in the market also. So sometimes with the high dose of overall, means high dose of estrogen progesterone pills, this thing is not working to control the bleeding. Then Equivera injection, the testosterone injection used to be given for 3 days and bleeding used to fantastically stops.
Not available now, not given.
Not available.
It is not available now. Yes,
according to the guidelines, also not suggested.
Yeah.
Yes.
Yes.
The
How does
guidelines doesn't.
bioflavonoids act, Dr. Sujal?
I am not using it, madam. I'm not using it, so I'll not be right person to.
Anybody can take this?
No.
We are not
We are
using.
giving the
Long back Venismin used to be given. But
they are saying that they can be given whenever there is acute bleeding and there is a lot of bleeding, because they will decrease the venous tone, increase the capillary flow.
When I was PG, they used to give, madam.
Long back.
And also,
I have seen patients coming to me with severe bleeding. The only tranexamic acid doesn't work in those cases when we combine with, initially used to be available in the form of Deflon, now in Venusimin.
Yeah.
So it is definitely effective in acute bleeding, and when combined with tranexamic acid and without hormone also, it's very, very effective.
even the hematologist suggests to take this, madam, in cases of acute bleeding.
Yes.
So the mode of action is not correctly known. The mode of action
commonly used
what about the centrocuman?
We are coming to that.
Okay.
So, Dr. Kavita, this is for you. What about ormofloxacin?
So actually, it is a non-steroidal and non-hormonal oral contraceptive, but can be given in women during the perimenopause to control bleeding. So it is generally given as once a week, sorry.
Twice.
But how does it work?
It is actually a selective progesterone receptor modulator, and it modulates the P receptor activity with some anti-proliferative effect on these, especially in fibroids. It has this effect.
And there is a increased risk of endometrial thickness with ornithloxacillin, madam. That worries gynecologists rather than patients. Patients are happy, but we are worried.
I'm
But
sorry
in
to
few,
interrupt, ma'am.
I
Last
have done the
5 minutes.
study and I
Very well
found
said, because it does not cause cystic enlargement, but it is reported that 15% may develop, which may develop these problem of amenorrhea. So it is
definitely it causes amenorrhea, but
there are a lot of myths.
in few
It
patients,
causes
I have
thickness,
done
but
around
it doesn't cause thickness. That is why I put this slide specifically to
yes,
break the
but
myths.
I have seen enough cases of fibroid. If it was a small fibroid, in out of my 200 cases, 3 patients had polyp and it was extruded out, increased in size. I don't know how. The fibroid was increasing.
I'm sorry to
Sorry,
interrupt,
madam.
ma'am. We have last
So,
4 minutes left.
Yeah, we have.
Last 4
Aditi is
minutes.
sitting there. Yes.
Yeah. So you have already said about the doses. So what are the options available for without structural lesion? We have already talked of other surgical. I am talking. Dr. Shweta. She's not there. Anybody can take this.
it's not there.
So we
Dr.
can do.
Shweta
Anybody can
cannot
take this.
join, ma'am.
So other options for the, without structural lesion, surgical options. Dr. Munshi, Sujal.
Basically, endometrial ablation can be done using electrocautery also, but because of the volume overload and its complications, it is becoming less and less popular. Microwave ablation is also available, which is also very effective. The cost of instrument is little high and most of them are single use, but that can also be offered to patients where surgery is not an option. And as a last resort, if things don't work out and patient is not willing for conservative, you can opt for hysterectomy, but save the uterus should be the bottom line.
Absolutely. So where we have to resort to hysterectomy?
So when the patient is more than 45 years and not willing to have medical treatment or LNG IUCD, and she is not, if there is endometrial hyperplasia with atypia and endometrial hyperplasia with comorbidities and risk factors, and in those cases we offer hysterectomy as a last resort.
And
Absolutely.
structural.
And structural causes.
So we have already talked about, I think we are going to avoid this structural causes, manage polyp. I think we have already talked about removing the polyp at the time of hysteroscopy. And this is a Doppler, and this is when we can't distinguish on ultrasound and we do not have 3D, then we can do SIS, and then treatment as hysteroscopic polypectomy, as we have already discussed. So what about endometrial hyperplasia? Anybody can take this.
So endometrial hyperplasia with atypia, without atypia. Without atypia, they can have treatment with the progesterones, with mainly metroxyprogesterone acetate or LNG IUCD.
LNG IUCD is the best, I think.
Yes. And
Yes.
with the atypia, if the patient has, if the woman has completed her childbearing and more than 40 years, better to opt for simple hysterectomy with bilateral salpingectomy. So if there is family history of breast cancer or colon cancer or other family hereditary cancer, we can opt bilaterally salpingo-oophorectomy also.
So a very LNG IUG grade A level 1, it is contraindicated for who are patient are not willing, or where we can also do oral continuous progesterone grade A level 1. And Dr. Suchitra, madam, are you there? What are the discrepancies in palm coin classification? Madam, is she there?
Yes, ma'am, she's there. Ma'am, if you can unmute yourself, please.
Yeah. So no, I personally feel, with the palm coin, it is good for classifying, but you're still missing out on certain things like, what are the undetermined origins, what are the unclassified causes, and most importantly, when you're talking of puberty menorrhagia, though we have the coin, it doesn't strictly fit into that. So I would have thought that the previous classifications could have merged better with the palm coin. But well, we have this currently, so we have to make the best use of it. And
Absolutely, ma'am.
yeah.
There
And
are,
second, yeah, sorry.
yeah. Yes, ma'am. Yes.
No, and I just wanted to, a couple of comments which I want to make is, people talk about people sampling looking at the West, but you can miss out so many, wherever you're suspecting, severe hyperplasia and in a perimenopausal age group. The important thing is you shouldn't be missing out. So you can do an office hysteroscopy or a hysteroscopy in the theater. You get a visualization and you get a better tissue diagnosis. Supposing you do a people sampling and you missed out and a pre-invasive CA or a CA, then it's bad for the patient. So I think I'm not a promoter of people sample at all. Younger age group maybe yes, but in the older 40 pluses, perimenopausal and little older women, I don't think that's a very good cause. Second thing,
Especially women who are at high risk, ma'am.
absolutely. And one important thing I wanted to say, Anju, was that when people just give hormones, you shouldn't write it on a piece of paper and forget about it. Please call the patient back, because many a times, as somebody very rightly pointed out, they use it for one cycle and then they feel better, they've forgotten. And then 3 months later, they come back and then the bleeding is again all over the place. So systematic between 6 to 9 months is what is the treatment recommended for any kind of an AUB, which is due to you're sure that it is due to a hormonal cause and not a typical structural cause. And third thing is, when we are talking of formuloxepin, somebody asked what is the contraindication. Well, any kind of a thromboembolic phenomena is a contraindication for formuloxepin. But in an acute AUB, it doesn't really work. It may work otherwise, but the doses are, not very 60 milligrams once a week. Then you have to do it twice a week initially, then reduce it to once a week. So it becomes a little difficult for patients to follow. So our standard progestogens actually work very, very well, provided you've done them, correctly, and call the patients back for a follow-up. So you get a much more better evaluation. You can change the medicine as per the requirement. And
Madam,
in the
what
old,
about your view on spread of malignancy when you do hysteroscopy?
no, you don't, because you keep the pressures, as Sujal very rightly pointed out, keep the pressures lower. You don't transmit any malignant cells through the ostia, because you keep it, you do it quickly, have a quick look and take a biopsy. That is much more better. Earlier thoughts, 10 years back, people thought, but no, there are many papers to say there is no risk of spreading of malignancy as long as you've kept the pressures low. So we are preferring a hysteroscopy because you can actually see, and as you very rightly pointed out, see and treat. If there's a polyp, you can remove it. If there's submucosal fibroid, you can remove it. If there's you feel a suspicious looking area, you can do a directed biopsy. So you're not really spending a lot of time. The only thing is sometimes the cervixes need to be dilated a little. So that under anesthesia, that will require a little bit of an anesthesia. So I think it is much more better and there is no risk of spread of malignancy.
Absolutely, absolutely. Very well given all the messages in a concise form
One
in a
doubt,
short.
excuse me, madam, one doubt. Nowadays, there came the OC pills containing Dynogest. So, what is your opinion regarding their usages in patients with adenomyosis, madam?
To be very honest, what I found is for adenomyosis, what works best is the LNG IUD. But if the patient is not willing for that, then you can use this combination or the oral contraceptives where the progestogen is Dynogest. The only problem with the Dynogest is patients do have a little bit of side effects, something like a hot flushes, night sweats. They do get it initially, but after 3 months, they're okay. But then you give it for 5 to 6 months. Ultimately, it is still systemic. Whereas with the IUD, it is local there, or it's like a monitor inside. So I find that for adenomyosis, the local marina works, LNG IUD works the best. And even that pain factor is much more lesser with a marina, plus there is a reduced menstrual flow.
That's the first line. I would call that as first line.
Absolutely,
Thank you so much, ma'am, for your expert insights. I would request Dr. Anju, ma'am, if you can just conclude the session, please. We are running out.
Yeah. Sorry. Sujal, can you take over this and conclude the session? Sujal? Sujal in this.
Yes, ma'am.
Munjal.
Yeah.
Please.
Thank you so much, Anju Madam and all the seniors and Sujal Bhai for making this interactive session. So informative in such a short span of time. And I'm really sure that the audience would have got the key points with regards to the AAB in perimenopause and all the utilities and investigations that is available to us. Thank you so much, ma'am. Thank you.
Thank you thank you, Dr. Suchitra, and all the panelists for giving beautiful take-home messages for each and every one. Of course, we had 4 cases. We couldn't take it because we wanted to cover each and everything so that it goes into the brain of everybody. We wanted to clarify the doubts. So
Thank you so
Thank
much,
you.
the
You have
moderators and
covered
the
very well
panelists.
all the aspects. Thank you very much.
Absolutely, ma'am.
Thank you
You
so much.
covered
Thank you
most
so
of
much.
the
Thank you,
aspects.
Lakshmi Shrikanda madam. Thank you, Anju Soni madam. Thank you, Suchitra Pandit madam.
Thank
Munjal
And
and
thanks to
Sujal.
ICOG for giving us this opportunity.
Absolutely. Thank you,
Yes.
ICOG.
Thank you.
Thank you, dear.
Thank you, ma'am. Now, I would like to request all the delegates to take the post test, the link of which would be shared in the chat box. Nilima, if you can please share the link of the MCQ.
Yes, ma'am.
So you will get 15 minutes to take the test. So you all can, the link is shared, so you all can start answering.
You can also scan this QR code.
The link. Those who are not able to open the link, you can scan the QR code and take the test.
Only 5 minutes left. Only 2 minutes left.
Last 1 minute left. The time
I
is
think
up.
all must have done. I think all must have done. The time is up, and questions were, I think, very easy also. What, Lakshmi Madam?
They were very easy questions, you know.
Yeah.
Tech team, please show the answers. Pratibha, please read the answers.
Yes. So, first question, the most common cause of AUB in adolescent is, answer is C. AUB in adolescent is classified as, answer is B. For question 3, answer is C. For question 4, answer is B. For question 5, first line treatment for heavy bleeding in perimenopause, answer is B. 7 is most common cause of postmenopausal bleeding, answer is C. Then 7. 8 is where women desiring fertility preservation with AUB should be assessed for, answer is C. For 9th, answer is C. For 10th, answer is B. For 11th, answer is B. For 12th, answer is C. For 13th, answer is C. For 14th, answer is C. For 15th, management of acute AUB in stable patient includes all except answer is C. And for 16th question, answer is B. For 17th, answer is B. For 18th, answer is B. For 19th, answer is A. And for 20th, answer is C. Okay.
I request Dr. Pratibha ma'am to give the final vote of thanks and conclude this excellent session.
Hello? Hello? Can you
Yeah,
can
we
you
can
can
hear
you
you.
hear me?
Yeah, we can hear you.
Okay.
Yes,
So,
Pratibha.
so it has been a very informative and up-to-date certificate course of AUB, and one of the most common condition we always encounter in our daily practice. And this 3-day crash course covered everything from evaluation of management, including both medical and surgical approaches, and concluded with the management of AUB in special populations. So I'm sure it has been a great learning experience for all of you. And this course must have boosted your confidence in handling AUB more effectively. And I think I have no doubt that everyone you will pass with flying colors because questions were very simple and you must have understood everything in that. And I would also like to extend my heartfelt gratitude to Dr. Parag Binewale, Dr. Sarita Balirao ma'am, Dr. Sadhna Gupta madam, Dr. Sheila Mane ma'am, and all ICOG team for this wonderful opportunity. And a special thanks to Dr. Lakshmi Srikhande madam and Dr. Sunita and Meena Sawant for this support for preparing this module. And hats off to all the coordinators for managing the session so smoothly and efficiently. And I sincerely thank all the speakers, chairpersons, moderators, panelists, experts for their valuable insights and engaging discussions. The sessions were truly enriching throughout, and I'm confident that all delegates have greatly benefited. And I also want to happily share that attendance remained excellent on all the 3 days. So that is really very good. So congratulations, Lakshmi Madam. Once again, sincere thanks to ICOG for organizing such fruitful and informative program. And on a personal note, I would like to thank ICOG Chair Dr. Parag Binewale and Secretary Dr. Sarita Balirao ma'am for including me in this prestigious program and giving me the opportunity to serve as one of the convener of this important ICOG certificate course. And last but not the least, Nilima, thank you for all help which you have given to us. Thank you all and good night.
Yeah, just 1 minute. There are so many concerns regarding the certificate of the past courses. Dear delegates, believe me, our ICOG staff is working very, very hard to email you certificates within 1 month. And Nilima is here on ICOG website. You can find the ICOG email. You have to have patience. Keep writing on the email. Sometimes if you don't qualify, the ICOG staff, they don't send you any mail. ICOG office sends certificate to all those who have qualified to receive the certificate within 1 month. If you have not received, it means that you have not qualified. Either you have not given test for all 3 days or you have not qualified on the basis of your score. So next time there is lot of it for you to improve. See to it that your internet connection is up to the mark, because many delegates have posted that because of this, because of that, because of network issues. Please see to it. You all are tech savvy, that your internet connection is up to the mark. Constantly our technical team is putting the link and we are giving 15 minutes. And to top of it, we are having added the QR code also for your ease and convenience. So I understand your frustration that you are not getting certificate, but there are many reasons behind it, and ICOG staff is always there at your service. So just write an email to them and keep following up with your email. Nilima is here. She is listening to me. Nilima, please you also look into their concerns and grievances. Yes, Sarita, I saw you. You want to say anything? Yeah.
Lakshmi, I have joined. I am in the car, so I'm not turning on my video. But
Yes,
just
Parag,
wanted to thank you, Meena and Pratibha, for doing an excellent work. This was one of the certificate course which had maximum attendance. And I must appreciate today's coordinators. I can see Aditi, Soumya, and Aishwarya. Very
Thank you,
well
sir,
done.
for the
Sarita, you can
opportunity.
formally propose the vote of thanks.
who is proposing?
Sarita.
Parag, that
Sarita
is
madam.
close to you. That
Done. We have done.
we had 1700 registrations for this course. So hats off to you, Sarita, the whole ICOG team, and my co-conveners, Meena and Pratibha. And I'm sure, I mean, delegates must have been benefited with, this is the first certificate course on abnormal uterine bleeding. And I'm sure everyone must have been benefited by it.
Congratulations,
Sarita
Dr. Lakshmi, Dr. Pratibha, Dr. Meena. It's been wonderful. Nice to see everyone. Nice to see Dr. Anju
Congratulations,
Soni, Dr.
Lakshmi.
Aditi.
Great job.
Thank you, madam.
Great job, great job.
Yeah.
So we'll meet again next month with the next certificate course on adolescent health.
Okay, म्हणून सांगू दे ना. Thank you.
See you.
Right.
Bye.
Okay. Thank you.
Okay,
Bye.
bye. Bye. Thank you. Thanks.